Good afternoon, everyone. We will begin the meeting in approximately 1 minute. Okay, Dr. Romero, would you like to call the meeting to order?
I would. Thank you very much, Dr. Cohen. So I'm gaveling the meeting to order. This is the emergency meeting of the Advisory Committee on Immunization Practices, ACIP, November 27th, 2020. We'll turn it back over to Dr. Cohen. Thank you, Dr. Cohen.
Good afternoon, everyone. Next slide. Welcome to the December 1st, 2020 emergency ACIP meeting. On our ACIP website, you will find the agenda, the webcast link, and the Federal Register notice will be posted in the next 24 hours regarding this meeting. Next slide. Copies of the slides presented at today's meeting are also available on the ACIP website. With apologies, they may not be available right this minute, but they are being put up as we speak. The live webcast videos will be posted on the ACIP website after the meeting. Meeting minutes are posted on the ACIP website generally within 90 to 120 days of the meeting. However, a short summary of the meeting minutes will be available at the end of this week. For your background information, if you wish to read the brief summary from the meeting that occurred a week ago last Monday, that meeting summary has been posted on the ACIP website. Next slide. I'm going to review several meeting logistics for those of you who have been at these meetings. You'll know how it goes, but there will be several new people at the meeting today. So the ACIP members, liaison members, and ex officios, as well as the speakers, are in this meeting through a Zoom call. The rest of the audience is watching this meeting on a live webcast. We ask that all of the individuals on the Zoom call mute your lines at all times until you're called on for discussion. And when Dr. Romero opens the meeting for discussion, please virtually raise your hand. During the discussion period, Dr. Romero will take questions first from the voting ACIP members and then from ex officio members and liaison representatives. Please disable your video for now if you're a liaison member. During the discussion period, we will be asking the ACIP voting members to turn on their videos so we can identify who's speaking during the discussion. Next slide. The meeting's oral and written public comment processes are designed to accommodate increased public interest in ACIP's work, maximize opportunities for comment, make public comment more transparent and efficient, and create a fair process for assigning limited oral public comment time. There is a docket that is available to input your written public comment on the Federal Register. The docket number is CDC-2020-0121. The docket is open now and will be open through December 3rd of this week. I also want to acknowledge that we had over 75 requests for oral public comment, and we had to limit that number to 10. So if you were unable to make an oral public comment, we encourage you to submit a written public comment. Additionally, if you sent public comment to the ACIP mailbox or to any individuals, please go back and and submit that in the federal registry if you would like for that comment to be reviewed and on the record. Next slide. Members of the ACIP agreed to forego participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, CDC has issued limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but these members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains on all votes related to the vaccines at the company of that company. At the beginning of this meeting, during roll call, ACIP members will state any conflicts of interest. Of note, the proposed recommendations that we are asking for ACIP's advice on today are general recommendations regarding COVID-19 vaccines and do not and are generalizable to all companies. And so therefore, while conflicts of interest will be stated, all ACIP members will be able to vote today. Before I turn it over to Dr. Romero, I would like to briefly review the agenda. You can find this agenda on the ACIP website, but after introductions, we will have a session reviewing the allocation of initial supplies of COVID-19 vaccine during phase 1A, and then clinical considerations for populations included in phase 1A. Following that, there will be a discussion, there will be a presentation on the post-authorization safety monitoring update, and then there will be time for discussion. Prior to the break at 4 p.m., if ACIP is ready, we will ask for ACIP to put a motion on the table for consideration. After the break, we will come back at 4:10 for public comment. We ask that all public comments focus on the motion that has been put on the table for consideration, and that all public comments be related to COVID-19 vaccines for this meeting. And after the 30-minute public comment period, we will have a vote on the allocation of initial supplies of COVID-19 vaccine. We anticipate adjourning the meeting today at 5 p.m. Eastern Standard Time. Next slide. Thank you all for listening and watching today. I'm going to turn it back over to Dr. Romero to take roll call of the ACIP members and to and the ex officios and liaison members. Thank you.
Thank you very much. Let me begin by correcting an error. It is the December 1st, 2020 ACIP meeting. So I will call the voting members' names. Please indicate your affiliation and if you have any conflicts of interest. So I will begin. Jose Romero, I'm the chair, Secretary of Health for the state of Arkansas. I'm a professor of pediatric infectious diseases at the University of Arkansas for Medical Sciences. No conflicts of interest. Dr. Atmar.
Thank you, Dr. Romero. Robert Atmar. I'm a professor in the section of infectious disease, Department of Medicine, Baylor College of Medicine. As a conflict, I'm a co-director of the Clinical Operations Unit of the NIH-funded Infectious Diseases Clinical Research Consortium that is working with the COVID-19 Prevention Network, or COVID-PN, to evaluate SARS-CoV-2 vaccine candidates in phase 3 clinical trials, including those produced by Moderna, AstraZeneca, Janssen, Novavax, and Sanofi. And I have participated in the conduct of the Moderna phase 3 trial. Over.
Welcome and thank you. Dr. Alt.
My name is Kevin Alt, and I'm I'm a professor of obstetrics and gynecology at the University of Kansas in Kansas City, Kansas, and I have no conflicts of interest.
Thank you. Welcome. Ms. Bata.
Good afternoon. This is Lynn Bata. I'm a public health nurse and serve as the immunization clinical consultant at the Minnesota Department of Health, and I have no conflicts. Thank you.
Thank you. Welcome. Dr. Bell.
This is Beth Bell. I'm a clinical professor in the Department of Global Health at the University of Washington, and I have no conflicts.
Welcome and thank you. Dr. Bernstein.
Good afternoon. I am a professor of, this is Hank Bernstein. I'm a professor of pediatrics at Zucker School of Medicine at Hofstra and Northwell, and I have no conflicts.
Welcome and thank you. Dr. Fry.
Good afternoon. This is Sharon Fry. I'm a professor of internal medicine in the Division of Allergy and Infectious Diseases at St. Louis University, and I am currently a site PI for the Moderna study and the Janssen vaccine studies.
Welcome and thank you. Dr. Hunter.
Paul Hunter, Associate Professor of Family Medicine and Community Health at the University of Wisconsin in Madison, Wisconsin. I own a small amount of Pfizer stock. I have a very small grant from Pfizer Corporation regarding a quality improvement project related to pneumococcal vaccines. Thanks.
Thank you and welcome. Dr. Lee.
Grace Lee. I'm Associate Chief Medical Officer at Stanford Children's Health, Professor of Pediatrics at Stanford University School of Medicine, and I have no conflicts.
Thank you. Welcome. Ms. McNally.
Veronica McNally, President of the Franny Strong Foundation, based in Michigan, and I have no conflicts.
Welcome. Thank you. Dr. Paling.
Good afternoon. This is Kathy Paling. I am Professor of Pediatrics and Epidemiology and Prevention at Wake Forest School of Medicine. I also serve as the Director of Pediatric Population Health. Thank you.
Thank you and welcome. Dr. Sanchez.
Hi, Jose. This is Pablo Sanchez. I'm a professor of pediatrics in the divisions of neonatology and pediatric infectious diseases at Nationwide Children's and The Ohio State University in Columbus, Ohio. I have no comment.
Thank you. Welcome. Dr. Szilagyi.
Hi, Peter Szilagyi. I'm professor of pediatrics at UCLA and executive vice chair and vice chair for research in the Department of Pediatrics, and I have no conflicts.
Welcome and thank you. Dr. Talbot.
Hi, I'm Kip Talbot at Vanderbilt University Medical Center, where I'm an associate professor in infectious diseases.
Any conflicts, Dr. Talbot?
Sorry, no conflicts.
Thank you very much. Welcome. I'll now turn to the ex officio representatives. I will name only the centers from which you're at, and please indicate your name. We'll go forward. First, Centers for Disease Control and Prevention.
Nancy Messonnier for CDC, thank you.
Welcome. Centers for Medicare and Medicaid Services.
Mary Beth Hance for CMS, thank you.
Thank you. Food and Drug Administration.
Good afternoon, Doran Fink for FDA Fever Office of Vaccines.
Thank you and welcome. Health Resources and Services Administration.
Captain Dale Mishler, Division of Injury Compensation Programs.
Thank you. Welcome. Indian Health Service.
Good afternoon. Jillian Doss-Walker, Indian Health Service.
Welcome. National Institutes of Health.
Good afternoon. John Bible from the NIH.
Thank you. Welcome. Office of Infectious Disease and HIV/AIDS Policy.
David Kim, OIDC.
Thank you. Next will be the liaison representatives. I will again list your institution. Please provide us your name. Begin. American Academy of Family Physicians, please.
Pamela Rockwell, present.
Thank you. American Academy of Pediatrics.
Bonnie Maldonado, a professor of pediatrics, epidemiology, and population health, Stanford University.
Welcome. American Academy of Physician Assistants.
Good afternoon, Marie-Michelle Léger, American Academy of PAs.
Thank you. Welcome. American College of Nurse Midwives.
Carol Hayes, present.
Thank you. American College of Health Association.
Sharon McMullen, Cornell University, and joined by my co-liaison, Tavi Chai, University of North Carolina, Chapel Hill.
Thank you. Welcome both. American College of Obstetricians and Gynecologists.
Dr. Eckert, present.
Thank you. American College of Physicians.
Dr. Jason Goldman, Assistant Affiliate Professor at Florida Atlantic University and Nova South Eastern University, present.
Thank you and welcome. American Geriatric Society.
Ken Schmader for AGS. Thanks.
Thank you. America's Health Insurance Plans.
Yeah, this is Bob Gluckman. I'm an internist chief medical officer for Progress Health Plans here for AGS. Thank you.
Thank you. American Immunization Registry Association.
Good afternoon, Rebecca Coyle representing ERA.
Welcome. American Nurses Association.
Chad Riddle representing the ANA.
American Medical Association.
Sandra Freihofer, Adjunct Associate Professor of Medicine, Emory University School of Medicine, and Liaison for the American Medical Association.
American Osteopathic Association.
Stan Grog, present.
Thank you. American Pharmacists Association.
This is Steve Foster.
Thank you. Association of Immunization Managers.
Hi, this is Molly Howell, Immunization Manager for North Dakota and Liaison for AIM.
Welcome. Association for Prevention, Teaching, and Research.
This is Paul McKinney. I'm Professor at School of Public Health and Information Sciences, University of Louisville.
Thank you. Association of State and Territorial Health Office Officials.
This is Nirav Shah, the Director of the State of Maine Center for Disease Control, here on behalf of ASTO.
Thank you. Biotechnology Innovation Organization.
Good afternoon. Phyllis Arthur, Vice President, Infectious Diseases and Diagnostics Policy.
Welcome. Council of State and Territorial Epidemiologists.
Dr. Christine Hahn, State Epidemiologist of Idaho.
Thank you. Canadian National Advisory Committee on Immunization.
Carolyn Quash, NACI Chair. Good afternoon.
Good afternoon. Welcome. Infectious Diseases Society of America.
Carol Baker. Here.
Thank you. International Society for Travel Medicine.
Elizabeth Barnett, Boston Medical Center for ISTM.
Thank you. National Association of County and City Health Officers. Officials, excuse me.
Matt Zahn, present.
Thank you. National Association of Pediatric Nurse Practitioners.
Patsy Stinchfield for NAPNAP.
Thank you. National Foundation for Infectious Diseases.
Marla Dalton for NFID.
Welcome. National Medical Association.
At Whitley Williams, Professor of Pediatrics, Rutgers Robert Johnson Medical School. Thank you.
Thank you. Welcome. Pediatric Infectious Diseases Society.
Don O'Leary, University of Colorado, present.
Welcome. Pharmaceutical Research and Manufacturers of America.
Good afternoon. Corey Robertson, present.
Thank you. Society for Adolescent Health and Medicine.
Hi, it's Amy Middleman for SAM. Thanks.
Welcome. Society for Health Epidemiology of America.
This is Marcy Dries, Chief Infection Prevention Officer at Christiana Care, representing SHEA. Thank you.
Welcome. Thank you. Did I miss anybody by? Thank you. All right. So thank you all for giving up your afternoon or late morning, depending on your time zone. We'll begin now. So we will discuss COVID disease 2019 vaccines. Dr. Beth Bell will give an introduction. Dr. Bell, please.
Thank you, Dr. Romero, and welcome everyone. Thank you for participating in the first emergency ACIP meeting in which we'll be having a vote. I'll just mention that this is a particularly difficult time in the United States. I just noted that since we're averaging one COVID death per minute in the United States right now, in the time it takes us to have this ACIP meeting, 180 people will have died from COVID-19. So we are acting, I guess, none too soon. First slide, please. So as a reminder, at the November 23rd ACIP meeting, ACIP reviewed the evidence to recommendation framework, focusing on the public health problem, resource use, and equity domains, and then the values, acceptability, and feasibility domains. And we discussed in some detail the phased allocation of COVID-19 vaccines. Next, please. During November, the COVID-19 vaccine work group focused our discussions on further issues around phase 1A populations and the clinical considerations surrounding those populations that are proposed to be included in phase 1A. Next, please. Now, as you heard from Dr. Cohn, today's agenda includes a discussion of allocation of initial supplies during phase 1A by Dr. Kathleen Dooling, a presentation about clinical considerations for populations included in phase 1A by Dr. Sarah Oliver, post-authorization safety monitoring by Dr. Tom Shimabukuro. We will have time for public comment. And then there will be a vote on an interim recommendation for the allocation of initial supplies of COVID-19 vaccine in phase 1A. Next, please. I just wanted to mention one additional update from my last presentation on this subject, which was not very long ago, which is just to remind everyone that there are now 2 COVID-19 vaccine manufacturers that have announced filing with the FDA for emergency use authorization. Pfizer-BioNTech announced a submission to FDA on November 20th, and Moderna announced submission to FDA on the 30th of November. Next. So that's it for me. Again, taking this opportunity to show the names of all of the participants in the COVID-19 vaccine work group, which gives me an opportunity to thank them for their dedication and their input. Next, please. And all the CDC participants, again, to provide me with an opportunity to thank all of the CDC participants for their efforts in this regard here. And I think that's it for my slides. Yes, thank you very much. And we'll proceed with the rest of the agenda.
Thank you, Dr. Bell. So next is Dr. Kathleen Dooling, who will discuss allocation of initial supplies of COVID-19 vaccine, phase 1. Following this, we will entertain questions regarding her presentation and not discussing the populations at this point. Dr. Dooling, please.
Thank you, Dr. Romero, and good afternoon, everyone. Today, we will revisit phased allocation of COVID-19 vaccine in order to answer the following policy question. Should healthcare personnel and long-term care facility residents be offered COVID-19 vaccination in phase 1A? After we have reviewed the evidence, then clinical considerations and safety monitoring presented by my colleagues will return to this policy question. Recall that during the ACIP meeting last week, we reviewed evidence in 3 domains to inform allocation decisions. For the science pillar, the work group examined COVID-19 disease burden as well as the balance of benefits and harms in each group. Of course, details of the phase 3 data will further inform this area when they become available. For implementation, the work group took into consideration the values and acceptability as well as the feasibility of implementation in each group. And finally, the ethical principles that apply to each group, namely to maximize benefits and minimize harms, promote justice, mitigate health inequities, and promote transparency throughout the policy process. We used those 3 pillars to evaluate the proposed groups for phase 1 vaccination. ACIP discussed phased allocation with healthcare personnel and long-term care facility residents in phase 1A, essential workers who do not work in healthcare in phase 1B, and adults with high-risk medical conditions and adults who are 65 and older in phase 1C. In order to address the policy question before the ACIP today, we'll focus on the rest of this presentation on healthcare personnel and long-term care facility residents. Let's take a moment to review who these groups include. Healthcare personnel are defined as essential workers, paid and unpaid, serving in healthcare settings who have the potential for direct or indirect exposure to patients or infectious materials. There are approximately 21 million healthcare personnel working in settings such as hospitals, long-term care facilities, outpatient settings, home health care, pharmacies, emergency medical services, public health, and others. The second group under consideration are residents of long-term care facilities. About 3 million adults in the U.S. live in long-term care facilities, which provide a spectrum of medical and non-medical services, usually to frail or older adults unable to reside independently in the community. There are several different categories of long-term care facilities, including skilled nursing facilities. In general, those provide higher acuity care, including rehabilitation services. There are also assisted living facilities, where residents are provided help with activities of daily living, but may live in their own room or apartment within that facility. Other residential care facilities may provide specific services or cater to specific populations. Now let's review the science. For healthcare personnel, as of November 30th, there have been at least 243,000 confirmed COVID-19 cases, with 858 COVID deaths. Long-term care facility modeling that was presented to ACIP in August predicts more cases and deaths averted at a facility among everyone by vaccinating staff compared to vaccinating residents. COVID-19 exposure, both inside and outside the healthcare setting, results in absenteeism due to quarantine, infection, and illness. Vaccination has the potential to reduce healthcare personnel absenteeism. Older adults in congregate settings are disproportionately affected by COVID-19. Long-term care facility residents and staff accounted for 6% of cases and 40% of deaths in the U.S., despite the fact that long-term care facility residents account for less than 1% of the U.S. population. The skilled nursing facility population is approximately 1.3 million, and as of November 15th, had experienced almost 500,000 confirmed and probable cases and more than 69,000 COVID-associated deaths. Assisted living facilities are home to approximately 800,000 residents across the nation. And although surveillance is less systematic for these types of facilities, 28,000 confirmed and suspected cases were reported over 28 states, and more than 5,000 deaths were reported over 20 states. This figure shows the proportion of COVID-19 associated hospitalized patients in the COVIDNet surveillance system who were admitted from a long-term care facility. As you can see, more than 30% of hospitalized patients aged 65 to 74 were admitted from a long-term care facility, and more than half of hospitalized patients, COVID patients, 75 and older, were admitted from a long-term care facility. Now let's review the implementation considerations. A Harris poll was completed in August, and survey respondents were asked which of the following groups should receive priority when a COVID-19 vaccine is available. Survey respondents most strongly supported early allocation of vaccine to healthcare workers and seniors. While not expected to exactly predict COVID-19 uptake, influenza vaccine among healthcare personnel may give us some indication of COVID-19 vaccine acceptance. Overall, influenza vaccine coverage is high among healthcare personnel, with the highest rates of uptake among hospital workers and lower rates among workers in the long-term care setting. Another early indication of long-term care facility acceptance of COVID-19 vaccination is the overwhelming response to the Pharmacy Partnership for Long-Term Care program. CDC is partnering with 2 national pharmacy chains to offer on-site COVID-19 vaccination services for residents and staff of skilled nursing facilities and assisted living facilities. To date, 99% of skilled nursing facilities nationwide have enrolled in this program. The program provides end-to-end management of COVID-19 vaccination process, including cold chain management, on-site vaccination, and fulfillment of reporting requirements. But even with the Pharmacy Partnership for Long-Term Care program, COVID-19 vaccination implementation and achieving high levels of coverage in the long-term setting will still be challenging. This slide is an example of a simulation of 1 and 2 dose coverage among skilled nursing facility residents over time. Even if acceptance is high and 3 vaccination visits are made, because of the high turnover, the proportion of current residents who are vaccinated decreases over time. The situation will improve, of course, when vaccine is readily available in the community and adults can be vaccinated prior to admission. Now on to ethics. Vaccinating healthcare personnel supports the principle of maximizing benefits and minimizing harms through what we are calling the multiplier effect. In other words, protection of healthcare personnel leads to preservation of healthcare capacity and better health outcomes for all. Vaccinating healthcare workers promotes justice because healthcare personnel put themselves at risk and will be essential to carry out the vaccination program. Vaccinating healthcare personnel also has the potential to mitigate health inequities because the group includes a broad range of occupations, inclusive of low-wage earners and racial and ethnic minority groups. Vaccinating long-term care residents maximizes benefits by directly preventing disease in a high-risk group and minimizes harms by potentially reducing the burden on hospitals. The Federal Pharmacy Partnership Program can promote justice by facilitating equal access to vaccine across most long-term care facilities. The program has the potential to mitigate health inequities by reaching long-term care facilities across the socioeconomic spectrum. In summary, the work group felt that early vaccination of both healthcare personnel and long-term care facility residents was strongly supported by science, implementation, and ethical considerations. Here are some additional important considerations the work group wanted to share for Phase 1A. What's presented here are interim guidance for Phase 1A. Allocation policy will need to be dynamic and adapt as new information, such as vaccine performance and supply and demand, become clear. To that end, we will need gating criteria to move expeditiously from one phase to the next as demand saturates. And it's important to keep in mind that following vaccination, measures to stop the spread of SARS-CoV-2, such as masks and social distancing, will still be needed. And ultimately, this interim allocation is a short-term measure. The U.S. government has stated its commitment to making COVID-19 vaccines available to all residents who want them as soon as possible. During the last ACIP meeting, there were a number of important issues raised, and we wanted to take this opportunity before the vote to provide some additional information on those issues. And to summarize, for healthcare personnel, ACIP members and liaisons expressed a need for guidance on sub-prioritization of healthcare personnel when vaccine supply is very limited in the beginning. To address vaccination in pregnant or lactating healthcare personnel, as well as how to approach expected reactogenicity following vaccination. For long-term care facility residents, ACIP members requested more information on consent and assent within the facilities and plans on interpretation of reactogenicity and safety monitoring in this specific population. So that concludes my comments for the moment, and I return the microphone back to Dr. Romero.
Thank you very much, Dr. Dooling, for that excellent presentation. We will now open it up to the voting members for questions regarding the presentation only, please. I see Dr. Atmar has his hand up.
I do. Thank you, Dr. Romero. Thank you, Dr. Dooling, for a very clear presentation. I have a question about the pharmacy partnership. One of the arguments for performing vaccination in long-term care facilities at the prior meeting was that both the healthcare personnel working in the unit or the facility and the residents could be vaccinated at the same time. Does the pharmacy partnership vaccinate healthcare personnel, or is it only for the residents? And if it's the latter, can you further address that question about a potential advantage? Thank you.
Thanks for that question. The Pharmacy Partnership for Long-Term Care will, in fact, vaccinate residents as well as staff in the facilities.
Before I take the next question, does anyone else have a comment or question to dovetail onto Dr. Atmar's? Okay. Dr. Fry, please.
Thank you. I don't know if this is a fair question to ask at this time. If not, just please tell me. But there was a slide earlier that looked at, I believe, 1 and 2 doses of vaccine. And I was wondering if we have any evidence for any kind of efficacy after administration of a single dose of vaccine at this time. Thank you.
We don't have any evidence right now, but that is one of the questions that we'll be asking of the phase 3 data once it becomes available.
Again, any comments or questions that tail with Dr. Fry's question?
This is Dr. Atmar. I have a brief follow-up on the same issue, but it doesn't relate to efficacy, but it relates to the challenge with the declining population and what the implementation plans would be to basically keep and complete vaccination in long-term care facilities. So it seems to be quite an implementation challenge. Over.
Thank you for that. I agree that it will be a challenge. The pharmacies that have signed up for this program have agreed to make 3 separate visits to the facility in order to vaccinate all persons who wish to be vaccinated. And again, once vaccine is more available in the community, this will be less of an issue.
Any other comments in that vein? Okay, Dr. Fry, your hand is still up. Is there anything else?
No.
Thank you. I'm just making sure that everybody has a chance to speak. Dr. Goldman, please go ahead.
Thank you. First, thank you to the committee and the staff for all their hard work and consideration on this difficult issue. I did want to stress a few points in concerning the phase 1 prioritization, especially of healthcare workers, and guidance on sub-prioritization. The outpatient community physician and small private practice truly being the backbone of the healthcare system, I'm pleased to see it's considered in healthcare first phase, but we need to really look at the outpatient offices being most at risk. There was a recent study out of the University of Pennsylvania that showed small community and outpatient physicians may be at a higher risk of death than the inpatient. And when you look at potential mitigation strategies, for example, an ICU physician, while seeing sicker patients, may have greater access to PPEs compared to small offices. I'm greatly concerned about the ability for the small and private practice to be able to get appropriate vaccination, especially from large healthcare systems. Additionally, the office staff is critical to running the small practices almost as much as the necessity of the physician being there, and they truly are the frontline workers. So I would hope that the committee would greatly look at the guidance and sub-prioritization, especially with vaccine distribution for those offices who are not employed by hospitals and not associated with large healthcare systems, to make sure we are truly getting the vaccines to the people on the front lines who need it the most, more specifically the small, private, independent community primary care physicians. Thank you.
Thank you, Dr. Goldman. Does anyone have a comment or a question to tail on to Dr. Goldman's topic? I see none or hear none.
Dr. Romero.
Please go ahead and speak up. Don't hold your hand up. Just add to that. Go ahead, please.
Yeah, this is Sean O'Leary with the Pediatric Infectious Diseases Society. I want to second Dr. Goldman's point there about outpatient providers and just add that also consideration should be given to other people that work outside of hospitals, like home health aides and EMS, et cetera, that plans should be made for those providers as well.
Thank you very much. Anybody else to add a comment to what has already been said?
Sorry.
Dr. Sanchez, I hear you. Go ahead.
No, I just want to echo that, because I do think that with sub-prioritization, and a lot of that I think will be left to jurisdictions, presumably, I do think that that the availability of PPE will be critical in terms of what subspecialty and what practices should be allocated to first. So I do want to agree with that.
Thank you very much, Dr. Sanchez. Anybody else adding to Dr. Goldman, Dr. O'Leary, or Dr. Sanchez's comments?
Sandra Freihofer, American Medical Association. Well, also wanted to emphasize the importance on making sure that small community practices have access to COVID-19 vaccines.
Thank you very much. There is some data in Dr. Oliver's next presentation that deals with this. So if you have other comments, we're fine to take them, but there will be some information coming. Anyone else wish to make a comment?
Dr. Romero, this is Jeff Duchin from IDSA. Can I make a comment?
No, of course. Please do, sir.
Thank you. I would just like to add that on the science front, that the transmission dynamics of COVID-19 also suggest that those providers that care for patients earlier in their course of illness may be at higher risk. This is supported by information CDC has recently published as well, and that would include outpatient healthcare providers. And thank you.
Thank you. Anyone else before I take Dr. Bernstein's question? I hear none. Dr. Bernstein, please go forward.
Thank you. First, I wanted to thank Dr. Dooling again for an excellent presentation, as she always gives. My question relates to the long-term care facilities and the potential for sub-prioritization. Is it envisioned that the healthcare personnel will first get vaccine in a long-term care facility if supply is constrained before giving it to the residents? Or is there another sub-prioritization scheme?
Dr. Bernstein, this is Amanda. I would assume that most planning around long-term care facilities would have a long-term care facility vaccinate both residents and health care personnel working in that facility at the same time. But there will be some jurisdictions that will likely start with healthcare personnel and then vaccinate residents. It's very dependent on supply and local context.
Thank you.
Thank you, Dr. Cohn. Anybody wish to add additional questions or comments to the topic brought up by Dr. Bernstein?
Yes, Dr. Ramirez, I have similar concerns about making sure that the staff in long-term care facilities are getting vaccinated. They too, as mentioned by others, are often less equipped in terms of personal protective equipment and have certainly had a huge burden of disease among them.
Very good, thank you. That was Ms. Bata, a voting member of the ACIP. I'm just stating your name for whoever is transcribing. Are there any other comments on this topic?
Hi, this is Marie-Michelle Leger from AAPA. This is in relationship to the long-term care residents. I know in previous discussion we made mention that there's a high turnover of the residents, and usually within a 30-day time period. So the question is more from an implementation and follow-up of those residents for their second dose, and the challenge that may entertain because of that.
This is Dr. Cohn. I can respond to that. You are highlighting one of the many challenges with ensuring high coverage among long-term care facilities, both of residents and staff. The turnover in long-term care residents, it tends to be a portion of residents turnover frequently, and then the additional residents are more long-term. So there will need to be additional visits to the long-term care facility, and we have data systems in place to support those individuals who leave the facility and getting a second dose. But that will be a challenge, particularly in the first couple of months of vaccination, where the places where you can get vaccinated will be more limited than when we have more supply.
Thank you, Dr. Cohen.
Yeah, this is Bob Gluckman from AHIP. I do feel that the opportunity to immunize residents at the time as the healthcare workers in long-term care facilities is important, because logistically it'll be much easier to get people administered at the same time. Really, the question that is asking is, what's the recall system? It would seem to me like the skilled nursing facilities could schedule people for one of the subsequent second or third days that the pharmacy is coming on site again, and then it's just a transportation issue. I think there are ways to do this logistically, and I really do endorse the efficiency that can be gained by co-administering residents and healthcare workers at the same site at the same time. Given this relatively small numbers, it doesn't have a meaningful impact on delaying vaccination for other populations, such as essential health workers or others that would be phased in at a later place. So I think the logistics can be overcome with thoughtful planning.
Thank you, Dr. Goldman. Anybody else wishes to add to this train of questioning and comment?
Yeah, this is Peter Szilagyi. I was thinking exactly the same as Dr. Gluckman, that it just seems efficient to vaccinate both the residents and the healthcare personnel around them. And I did have a question about the type of personnel, the type of residents who are in the long-term care facilities. And I do know that there are those who kind of cycle through very quickly, and then the proportions stay very long. Do we know about the COVID deaths, and which of those groups? My guess is that the vast majority of the COVID deaths are not the ones who are in long-term care facilities for rehab for a very short amount of time, but because sort of the other more truly long-term patients.
This is Dr. Cohen. We don't have that data at our fingertips, but that is a good question, and we will look into that. Thank you.
Yeah, this is Bob Gluckman. I would just comment, I don't know that we know that. I mean, some of the patients that are in long-term care facility are for acute medical illnesses where they need some short-term health. I can tell you that from our diagnoses from a health plan point of view, there are lots of patients who need short-term help with conditions like sepsis, post-pneumonia care, congestive heart failure. It's not just joint replacement. Those are not in long-term care facilities as much as they used to be. So I'd be cautious about prejudging who's at most risk and thinking that the short-term residents are not.
Thank you.
Thank you very much. We're going to move on to the next question. There'll be plenty of time during the discussion section to add more to this if you wish. So let me turn to the next hand that's raised. Excuse me. Dr. Fry, do you wish to ask another question?
Yes, please. So I just want to mention that if people in long-term care facilities, particularly the elderly, are going to be batch vaccinated, if you will, that this is another situation where there's going to be we'll need to have a lot of guidance post-vaccination to evaluate symptoms or adverse events or side effects, because if the elderly suffer from fatigue or even a little fever, people worry about them having underlying infections and this sort of thing. And so if there's more than just a few people suffering from those side effects, it will perhaps cause issues at the home.
Thank you for that comment. And I'd like to say that our next presenters will address exactly those issues.
Thank you very much. Dr. Dries.
Oops, sorry, I couldn't get myself unmuted fast enough. No, I think I was just going to say something along the same lines around healthcare personnel as well. And I think it sounds like it will be covered in the next presentation around having very specific guidelines around managing symptoms.
Thank you very much. Dr. O'Leary.
Yeah, could you just clarify, so there are pediatric long-term care facilities, and could you just clarify for the jurisdictions that we're talking about adult facilities, or since the Pfizer vaccine may go down to age 16 in its approval process, are those 16 and 17-year-olds in long-term facilities considered in this vote as well? Thank you.
The recommendation that we'll be voting on today pertains to adults, and the specifics of the age cutoff will be determined once we have a specific vaccine that has been authorized.
Thank you.
Are there any other questions or comments before I close this presentation? I see none and hear none. Thank you all very much. So we'll move on to the next presentation by Dr. Sarah Oliver on the clinical considerations for populations included in phase 1A. Dr. Oliver, please.
Thank you. So, good afternoon. This afternoon, I will be presenting clinical considerations for populations discussed for potential inclusion in Phase 1A, healthcare personnel and long-term care facility residents. This includes sub-prioritization, reactogenicity, and considerations for implementation. One or more COVID-19 vaccines may be authorized by FDA for use in December. However, the initial doses of any COVID-19 vaccine will be limited. We expect a constrained supply environment for some months and need to make the best use of available vaccine. By the end of December, the number of doses available will be around 40 million, enough to vaccinate around 20 million people. That won't all be available at the same time, however. We anticipate 5 to 10 million doses per week post-authorization, which could lead to a need for sub-prioritization of the initial populations, at least for the first several weeks. Next, for healthcare personnel, where sub-prioritization of healthcare personnel is needed, consider individuals with direct patient contact who are unable to telework. This includes personnel who provide services to patients or patients' family members, and persons who handle infectious materials. This can also include both inpatient and outpatient settings. Also consider personnel working in residential or long-term care facilities, and personnel without known infection in the prior 90 days. Reinfection appears uncommon during the initial 90 days after symptom onset preceding infection. However, serologic testing is not recommended prior to vaccination. Next, for pregnant or breastfeeding women, as has been discussed over the last several ACIP meetings, 75% of the healthcare workforce are female, and there could be over 300,000 healthcare personnel who are pregnant or recently postpartum at the time of vaccine implementation. Data demonstrate potentially increased risk for severe maternal illness and preterm birth due to COVID-19 disease. However, this must be balanced with the fact that there are no data on the use of mRNA vaccines in pregnant or breastfeeding women. We await Phase 3 data, an FDA assessment, and the EUA conditions of use. Once reviewed, we anticipate further guidance around the use of COVID-19 vaccines in pregnant or breastfeeding Phase 1A populations. Reactogenicity post-vaccination will be a concern among vaccinated healthcare personnel. We will have additional data soon from the Phase 3 trials. This is the current data from the phase 1-2 trials with vaccine doses used in the phase 3 trials. While the numbers here are quite small, you can see that systemic symptoms are more common after the second dose. There are several considerations for implementation. Healthcare systems and public health should work together to ensure vaccine access for healthcare personnel who are not affiliated with hospitals, which could include home health, community services, or broad practice types. Next, consider staggering vaccination of personnel from similar units or positions. In addition, consider planning that personnel could have time away from clinical care if healthcare personnel experience systemic symptoms post-vaccination. And on that issue, we wanted to let you know that there is additional CDC guidance forthcoming describing the approach to systemic symptoms in healthcare personnel after COVID-19 vaccination. This will provide detailed information for how to handle these systemic symptoms in healthcare personnel. It isn't ready to share today, but it will be available on the CDC website before any vaccine doses are administered. Next, for clinical considerations for long-term care facility residents. As was mentioned before, long-term care facilities provide a spectrum of medical and non-medical services to frail and older adults unable to reside independently in the community. Skilled nursing facilities and assisted living facilities are both considered types of long-term care facilities. Skilled nursing facilities are engaged primarily in providing skilled nursing care and rehabilitation services for residents who require care because of injury, disability, or illness. Assisted living facilities provide help with activities of daily living. However, residents often live in their own room or apartment within buildings or group of buildings. Regarding COVID-19 disease among the long-term care facilities, as of November 26, there have been around 730,000 COVID-19 cases and 100,000 deaths among long-term care facility residents and staff. As of mid-November, skilled nursing facilities have reported nearly 500,000 cases and 70,000 deaths through CMS. Reporting varies for assisted living facilities, but through October 15th, 23 states reported nearly 28,000 cases and 20 states reported 5,500 deaths. Therefore, where sub-prioritization of long-term care facilities is needed, consider skilled nursing facilities, which care for the most medically vulnerable residents. Then, after skilled nursing facilities, consider broadening to other facility types, including assisted living facilities, residential or intermediate care facilities, or state veterans' homes. Next, reactogenicity for the older adult populations. While we don't have data from long-term care facility residents specifically, we do have data from the phase 1-2 trials among community-dwelling older adults with the ages listed here. Systemic symptoms are generally lower among the older adult populations. The one severe reaction post-dose 2 in the Moderna trial was a report of grade 3 fatigue. There are considerations for implementation among long-term care facility residents. Federal pharmacy partners supporting the long-term care facility program will be required to adhere to all EUA conditions of use, including providing fact sheets to recipients. In addition to the fact sheets for staff and residents getting vaccinated, they will be provided to families and medical proxies as applicable. CDC will also provide language clarifying that while there is available data on safety and efficacy among adults 65 and older, there are no data on individuals in long-term care facilities. And importantly, consent or assent will be obtained from residents or families or medical proxies and documented in the patient's chart, as is standard practice for other vaccines. So in summary, sub-prioritization may be required with an initial limited supply of vaccine. Implementation of vaccination programs for healthcare personnel
will need to consider reactogenicity post-vaccination, and additional guidance is forthcoming from CDC. Reactogenicity appears lower in the older adult populations for mRNA vaccines, but there is no reactogenicity data in long-term care facility residents specifically. And safety monitoring, which will be described in detail in our next presentation, will be critical post-authorization for all populations in Phase 1A, especially long-term care facility residents. Thanks, and I'm happy to take any questions.
Thank you, Dr. Oliver, again, for another well-presented topic. Dr. Atmar, I see your hand is up.
Yes, sir. Thank you, and thank you, Dr. Oliver. I just have a comment about, a cautionary comment about comparing the community-dwelling older adults to the younger adults living in the community. 2 out of 12 versus 1 out of 12 is hardly reassuring, so I don't think we can really draw any conclusions about the relative frequency of side effects based on this limited data set. I know we'll have the data from the Phase 3 trial, which should provide us a lot more information, but I think it's too early to draw conclusions about the relative reactogenicity of the vaccine in these 2 different age groups. Over.
Thank you. Dr. Hunter, please.
Yeah, I just wanted to commend you all on the little detail about not having everybody who works on a particular unit get the vaccine at the same time. I had never thought about that, you know, the convenience of doing a vaccination unit by unit would be pretty high within a healthcare system, but that could wipe out that unit for a day, you know, 2 to 3 days later when people have their reactogenicity, or at least it could, you know, have quite a few of those people out of work. So I think that that level of detail is really highly valued by people who are actually going to be implementing this, and I just want to commend you on including that. Thank you.
Right, and let me just add a comment. It goes without saying that this applies also to emergency personnel. If you have a mass vaccination of EMTs, you could be extremely short of these individuals in the community. Dr. Sanchez, please.
That was excellent presentation, Sarah. Thank you. I just think that we should separate the lactating mother from the pregnant woman, because although we may not have data on lactation and transmission or safety there, we know that women with COVID-19 can breastfeed safely. And I really think that a healthcare woman who recently gave birth, who is working frontline and at high risk, I think that woman should be, personally, I think that woman should be vaccinated despite and continue breastfeeding as well. So I think that those are 2 different situations with much more safety in my mind in a woman who's only providing breast milk.
Thank you, Dr. Sanchez. Dr. Maldonado.
Thank you so much for these great presentations, and it's really been helpful for us in thinking about how to allocate across healthcare systems. And I think when you talk about the science, implementation, and ethics, we talk about disease burden, balance of benefits and harms, values of target group, et cetera. I think sub-allocation really comes into play here in much more granular ways when we really start looking at the tiered approach to these smaller aliquots of vaccines. So for example, I wonder if we could get some guidance when we're trying to look at our healthcare worker population, and all things being equal, if your populations are equally likely to be exposed in the healthcare setting, and you look at frontline workers, the question is, when do you weigh, for example, age greater than 65 among your healthcare population versus risk of exposure versus racial and ethnic disparities and risk for community transmission at home? So basically the bottom line is, are you really trying to prevent transmission in the hospital setting? Are you trying to prevent transmission to the healthcare worker specifically? And if so, which risks how do you balance those risks? That is the higher aged individual much more at risk than the person who comes from a racial, ethnic demographic that puts them at higher risk in communities? And then finally, what is the risk when you're trying to reduce disease burden? Obviously, the healthcare place is important, but are you trying to reduce community transmission for those individuals as well? So these are really a very entangled concepts, and I think we look to CDC and ACIP for further guidance on those very critical questions.
Thank you. Dr. Szilagyi.
Yeah, I was going to make very similar points to Dr. Maldonado. I'm on multiple groups that are trying to sub-prioritize within healthcare systems, and everybody's looking for guidance from ACIP or CDC. So I just want to emphasize the importance of guidance and the balance between being specific enough to help health systems, but allowing and suggesting and encouraging some flexibility because the health systems know their own populations the best. And I did have a question about as the guidance comes out, will there be discussion about sort of coordination with SHEA or other groups that are also in the space working on guidance for healthcare facilities and sub-prioritization?
Dr. Romero, this is Amanda. I just want to level set as we continue this conversation, this discussion, which is incredibly helpful. We anticipate having about 40 million doses, so enough to cover somewhere between 15 and 20 million individuals, which does cover a large portion of healthcare workers by the end of December. And then after that, each week we anticipate having somewhere between 5 and 10 million doses in that arena. So in essence, we're talking about subprioritization, but it is for a limited period of time in this population. And I think Dr. Oliver has some additional comments to address. All of y'all's comments have been incredibly helpful.
Yes, thanks. Just wanted to provide a little context around the work group discussions around this. I think the protection for healthcare personnel is both the direct protection for that individual as well as for the healthcare system as a whole. And each individual healthcare system is going to need to figure out their additional, if they have additional sub-prioritization balanced based on, doses and staff that they have, as well as weighing the individual privacy and protection around the individual healthcare personnel. Thanks.
Thank you. Dr. Hunter?
Yeah, thanks. I actually do have another question. You're saying that 20 million people could get vaccinated with the 40 million doses. But I'm wondering, are you saying that you're anticipating that those doses will be in people's arms by the end of December, or that they will be available to be distributed by the end of December?
I'm saying that if jurisdictions and providers place orders, they will be available, and we anticipate that most of those doses will be distributed. This depends on this goes back to the storage and handling requirements, but the jurisdictions have very detailed plans about how to ensure maximizing doses in clinics. That being said, it won't be 40 million doses equals 20 million people vaccinated, because we can't directly, there will be some dose mismatching in some areas.
This is Dr. Messonnier. I just want to add that in discussions with the jurisdictions, most of them believe that they can vaccinate all of their healthcare workers within 3 weeks. Now, that's certainly dependent on workforce and the hope that that there will be so much support for the vaccine that that the workforce will be able to kind of be drawn together. But from an operational standpoint, most of them are planning, frankly, some far less than 3 weeks, but to be able to actually vaccinate their healthcare workers quickly, if that helps put this in perspective in terms of sub-prioritization. Thank you.
Thank you. Dr. Hunter, did I cut you off?
No, that's just saying thank you for that answer.
Thank you. Dr. Dries, please.
Yes, thank you, Marcy Dries with SHEA. I just wanted to first comment that, yes, SHEA is very interested in working with CDC around healthcare worker subprioritization, as well as managing the reactogenicity of the vaccines in this population, and that work has already started. The other thing I wanted to call out was just the logistics involved with what's kind of a disconnect. You know, on the one hand, because of the characteristics of the vaccine, we really are looking at a high throughput, centralized vaccine distribution system, which then goes at odds with staggering vaccine across different units and departments, as well as requesting that people schedule their vaccine, you know, the day before they have a day off already scheduled. And those things are going to be very logistically challenging to manage. And I think, you know, from a large healthcare system, you know, I won't be able to manage, you know, which people on which units get vaccines on which days. We're really just going to have to manage that even at the unit level as much as possible. And then also, I think, you know, the smaller hospitals are going to have a really hard time. You know, when they have a 100-bed hospital, you know, they don't have enough staff to vaccinate, or, you know, they're going to have to order enough vaccines that would, you know, potentially vaccinate their entire staff within a day or two, which sounds like we don't want to do. So I think there's going to be a need for a lot of partnership between local and state health departments and smaller hospitals to distribute the vaccine in a way that makes sense and allows them to stagger it out over time. Over.
Thank you. Dr. Paling.
Good afternoon. This is Kathy Paling. I wanted to thank Dr. Oliver for a very clear presentation. And in particular, I thought the reactogenicity that's available from the trials, phase 1-2 trials, is particularly helpful as everybody's looking to identify how best to move these forward. And so, and it does highlight the importance of staggering, which is not going to be easy, but it does provide important information. Just saying thank you.
Thank you very much. Ms. McNally, please.
Thank you. How is the EUA fact sheet for recipients different from a vaccine information statement?
This is Dr. Cohn. The EUA fact sheet will actually be very similar to a VIS statement. The VIS statements are also reviewed and coordinated with FDA, but there will be it will be differently formatted, but a lot of the content will overlap, although it will be made more clear that this is under an emergency use authorization and make sure that the individual understands what that means.
Dr. Romero, may I ask one follow-up question?
Of course you may.
How often would the EUA fact sheet be updated with the accumulation of new data?
Dr. Fink, are you on the phone and available to respond to maybe this one and clarify my response to the earlier one?
Hi, could you repeat the question, please?
Yes, I'm wondering how often the EUA fact sheet would be updated with new information.
Right, the EUA fact sheet would be updated with any new information that FDA considers important to allow healthcare providers and vaccine recipients to understand the benefits and risks and options related to use of the vaccine under the emergency use authorization. I can't give you a specific time frame in terms of how often this might occur, because that would depend on when we might receive information that would warrant a change. Over.
Dr. Romero, I apologize. One more follow-up question. I had understood that the vaccine information statement had a public comment session. Is it similar for an EUA fact sheet?
This is Dr. Cohn. Dr. Fink, you may have additional comments, but there's not a public comment period for an EUA fact sheet. It is developed as part of the EUA authorization between FDA and the manufacturer. Dr. Fink, anything else?
Nothing to add. Thank you.
Ms. McNally, any other questions? No need for apology. The floor is yours until you cede it.
I appreciate it. Nothing else at this time. Thank you.
This is Dr. Atmar. I have a follow-up on that, though.
Go ahead, please, Dr. Atmar.
And that's just a point of clarification. The EUA fact sheet is given to all vaccine recipients, not just those working within long-term care facilities. Is that not correct?
Yes, that is correct. Additionally, there are fact sheets for both the providers and the individuals receiving vaccine.
This is Kathy Paling. I have another follow-up on that. And I wanted to clarify that EUA fact sheet would be available when any vaccine is authorized by the FDA. Is that correct?
Yes, there will be individual, and this is actually another difference between the VIS statements and the EUA fact sheets. Each product will have an individual fact sheet, whereas for the VIS statements, it's for the specific, the type, the disease in which it prevents, or the type of vaccine. But each, an individual will receive the fact sheet for the vaccine product that they receive. And this is all part of the EUA package. And providers will be trained rapidly on how to provide EUA vaccines under an EUA, including ensuring that that patients have this fact sheet.
Are there any more questions or comments on this topic? It seems to be particularly.
One more question. Thank you for the great set of comments and questions. And I know this is asking a lot, but I do wonder, and all of it will depend on what the phase 3 efficacy and safety data look like, if there are going to be differences in the benefit risk sort of counseling that's intended with the EUA fact sheet. And I think Dr. Atmar was getting at this, which was, is it plausible that it might be reasonable to have one that is tailored to long-term care facilities, for example, that would be different than generic EUA fact sheet specific for a healthier population?
So Dr. Lee, this is Amanda again. So the EUA fact sheets that are FDA authorized and sent with by the manufacturer will be the same for every individual. However, CDC is developing specialized toolkits for communications materials that will provide additional information and context around COVID vaccination, maybe not specific to each product, that should be available soon. And there will be the first one to roll out will be specifically for healthcare systems, vaccinating healthcare personnel. And then the second one right after that will be the long-term care facility toolkit, which will have information about what vaccination means for a long-term care facility resident and their family members.
Thank you. If I could just make one more comment, which is to say a huge thanks for putting together these implementation toolkits. I recognize how challenging it is to develop these communications in the absence of having the phase 3 clinical trial data in hand. And I also recognize that we as providers and healthcare delivery systems need to partner with you at CDC and our states and our jurisdictions in order to support these communications, and that it will be an iterative process, as it should be, in part because everything is happening on such a compressed timeline. But I just wanted to say and recognize how much work and effort I know that your team is putting in to help us be able to do this well. So thank you.
Thank you.
Dr. Atmar, one more question related to the EUA. Are there any sort of IRB reporting requirements if there are adverse events, or will that all be covered in the next presentation?
Dr. Fink, do you want to respond to that? He may be away.
Yeah, hi. So the EUA, if issued, will lay out requirements for adverse event reporting.
Thank you.
Next question by Dr. Stinchfield, please.
Patsy Stinchfield from NABNAB. I just wanted to comment on some of the practical considerations and as we sub-prioritize. I'm already working on this in my healthcare institution at Children's Minnesota. Our total employee population is 5,300 and our direct care providers are 3,300. And I think knowing we can only get data, so we don't have birth dates of people's in their files. We have their month and their date, but not their year for age discrimination reasons. We may not have race and ethnicity. We certainly don't have medical records and their own personal medical histories in an occupational health setting. And so we can only go down so far in terms of those sub-prioritization and mostly direct and indirect patient care providers. So as we ask those other 2,000 folks to hold on, Nancy, your comments about talking about weeks as opposed to months is very helpful to give people the guidance on when to expect their doses. So there's a lot of enthusiasm and understanding the time frame is really, really helpful. Thanks.
Thank you.
This is Jeff Duchin. Can I add to that comment?
Of course, please.
Thank you. Jeff Duchin, IDSA. So I am a member of the COVID-19 vaccine work group, and I wanted to make sure that the ACIP, the voting members, are clear about whether they feel the level of substratification guidance is adequate given what we expect with respect to supply. And with all due respect, we are never able to predict the future. And these supply issues may, although I hope not, they may go on longer than anticipated. And so should we have issues with supply exceeding insufficient to meet demand, do we feel that the substratification guidance, for instance, for healthcare facilities who have more healthcare workers than can be vaccinated, should there be any further guidance around equity considerations or other considerations in determining who gets vaccine first? And for example, should more facilities be given fewer doses or should fewer facilities be given more doses? So I'm interested in the comments of the ACIP overall and particularly those members who work in clinical care delivery settings. Thank you.
Open for comments.
This is Grace Lee. I'll express my opinion. I certainly believe that our goal in phase 1A with regard to healthcare personnel is to preserve the workforce and healthcare capacity regardless of where exposure occurs. And so, I do feel strongly that those who need to be in the workplace interacting with patients, families, and staff for their job function, and I want to highlight that this includes clinical support services such as nursing assistants, medical aides, environmental services, food services, front desk staff, are all a critical component of how we deliver healthcare. I am very mindful of the equity considerations, as we all have been throughout all these discussions. Making sure it reflects the distribution of the workforce early on will be important, and the workforce that's actually in place that needs to come into work to be able to function in their job. I think just a couple of comments on or discussion items related to medical conditions of healthcare workers and age, and those are clearly going to be important in phase 1C. I think my concern about the equity issue is that if we ask people to self-disclose, that it may inherently create some unintended inequities, and that I think some healthcare workers are more easily able to self-advocate and feel comfortable in their position and being able to declare medical conditions. So I worry by creating that as a construct that we might actually, again, unintentionally create more inequity in that if our lower wage workers don't feel comfortable self-disclosing medical conditions, we may effectively not be putting them, in the front of the line as they should be, given that I know at least in some institutions and in the national data, our lower wage workers are actually faced with higher rates of infections. whether it be from the community or whether it be in the workplace. And I think that if we run into supply issues for a longer period of time, it'll be important for us to make sure that we are focusing on phases 1B and 1C, and then as need be, our workforce who can stay from home and shelter in place until the spring or summer, certainly as they meet 1C or 1C conditions, should get vaccinated in that phase. But there are a portion of our workforce who can work from home without coming into the workplace until spring or summer. And so I will have a hard time personally allocating early on when I know that there are so many individuals out there who are in need.
This is Paul Hunter. Can I respond to Jeff Duchin's comment?
Yes, go ahead, Dr. Hunter.
Thanks. So, Jeff, I think what I'm thinking of is a process that's related to venues and related to gathering people who are making the decisions at the venue level, that is the unit of the healthcare delivery system, the healthcare delivery system itself, the local health department. Pick your size of venue you want to use as a unit. That those people, if they were brought together in relatively real time, maybe every week or so, to discuss the issues of their facing with allocation issues on a state level, on a federal level, on a national organizational level, in some kind of forum where they could discuss the issues they're having, compare it to what the consensus in a large group setting, either statewide or nationwide, is of how to interpret the general guidelines that the ACIP votes on. That's the way I think in practice I would see your issue being addressed, of how to have enough specificity in ACIP recommendations without at the same time having enough flexibility to implement them. I think it's going to require some national group having regular discussion sections of people who are actually doing it on the local and subunit level. That's just my opinion.
Thank you. I was muted there. Thank you, Dr. Cohen, for stepping in. So we will go forward then. Dr. Goldman.
Thank you. First, thank you to Dr. Oliver for a wonderful presentation, as always. Back to my earlier comments, and on a more granular level, concern for the implementation to the small and community practices and getting out to the community. When we look at these hospital systems, the CDC, we really need both guidance and perhaps oversight and really detailed gating criteria, because I would hate to see a large system get a huge amount of vaccine, vaccinate everyone, including those not necessarily at risk, like those working perhaps in the IT department who are not in patient care but are employed by a hospital, and it's not getting out to the community where it needs. So I suggest, or I don't know if it is even in the purview of the committee, but to make sure that the hospitals, the distribution sites have some gating criteria, some mandatory outreach to the community so that we're getting the vaccines where they need to be, because even in rural areas, there may be many physician practices, providers, et cetera, who don't even know where to go to get the vaccines or who's even distributing them if it's only being localized to those large healthcare systems. So on a granular level, we really need detailed guidance on how to get the vaccines implemented, especially to the community where it may be needed the most, as opposed to just the hospital systems itself. So that's one of my concerns, and hopefully the committee can see some way to ensure those vaccines are implemented properly. Thank you. Over.
Thank you. Dr. Freihofer.
Sandra Freihofer, American Medical Association. I have just a couple of comments. On Dr. Oliver's slide 7 on reactogenicity, does this refer to just healthcare personnel, or is that to all adults?
This is Dr. Oliver. The slide was all adults that received from the phase 1-2 trials that received the dose that is given in the phase 3 trials, regardless of their occupation.
Thank you. My next comment is about the EUA, the Emergency Use Authorization Form. Is this something that a patient signs? And, one thing I worry about in, talking about the frail elderly is making sure they really understand what they're getting and what the side effects from the vaccine would be. And if these patients aren't able to sign on their own, is there outreach to family members, whoever has their power of attorney, to sign for them? And
this is Dr. Messonnier. We can refer you back to the previous presentation where we went through in detail. We agree with your concerns. It's very important for the frail elderly, not only to ensure that they are understanding the vaccine that they're getting, but that also their family members do. And that's why we have put in special provisions in this long-term care facility program to ensure that that happens. We're happy to send you those slides again. But again, this is a space where we have been very concerned. And I think part of the issue is that we really are going to need everybody pulling together and working together to ensure that we're harmonious with our messages. As Dr. Cohn said, a big effort for us over the next, frankly, 2 weeks is to push out as much communication material as possible. And we really hope that as the ACIP community, we can make sure that you're fully briefed on our efforts so that you can then be briefing your counterparts. So definitely agree with your concern, and we've definitely put provisions in place. We hope to really manage that. Thank you.
Dr. Messonnier, this is Sandy Freihofer again, and thank you so much for that comment. And when you say that, I know you really mean it. So thank you. And my third comment is to echo Dr. Goldman's concerns about the importance of community outreach to healthcare people that might not be in the hospital to make sure that they get vaccinated. Thank you.
Thank you. Dr. Dushin, please.
I neglected to put my hand down. Thank you.
Thank you, sir. Dr. Sanchez, please.
I hope so. Yes, I just had another question in terms of the prioritization. And I think that, certain individuals, particularly those receiving biologics, and I know we probably will not have some data, but I think that it'll be important to include some of those in terms of what would we be recommending to those individuals.
Thank you. I think we're going to have to stop here and move on to the next presentation. There will still be a discussion following that presentation, which can cover any of the two previous discussions. So with that in mind, I'm very sorry. I'm going to ask Dr. Shimabukuro to come forward and to present post-authorization safety monitoring update.
Hi, can you hear me okay?
Yes, we can. Thank you very much.
All right, great. Next slide. So I'm going to start with the safety monitoring timeline and covered populations and early vaccination. Next slide. So I'm going to basically build out a timeline here where I'm going to show our safety monitoring systems and when they come online. And when I start with the very early monitoring systems, they are ordered from top to bottom. They will all be active and functional when vaccine becomes available. I've ordered them in the order which I think data may become available in them. And so I would like to start, next slide, by mentioning VSafe, which is a new vaccine safety monitoring system that CDC has stood up for COVID-19. It's an active surveillance program that uses smartphone-based tools to conduct check-ins, and we're doing primary data collection on adverse events that individuals might be experiencing after vaccination. And we also have the capability to do phone follow-up and take adverse event reports if these individuals report a significant health event. This should start, this requires registration, but is going to start collecting data immediately on day 0 and collects data out to 12 months after the second dose of vaccination. Next slide. So I want to also mention our passive surveillance or spontaneous reporting system, which is the Vaccine Adverse Event Reporting System, which is co-managed by CDC and FDA. And VAERS will be available immediately when vaccine becomes available, and we've ramped up to anticipate additional reporting for COVID. What you see on top there are some systems that report or feed into VAERS. DOD and VA actually run their own spontaneous reporting systems in their healthcare systems, and they report into VAERS. And we've also done work with the National Healthcare Safety Network to increase awareness of adverse events and to encourage reporting to VAERS. Next slide. And the Clinical Immunization Safety Assessment Project at CDC, which is a collaboration between 7 medical research centers and CDC, conducts individual case consults. They're staffed up and ready to go to start doing case consults, and that often gives us an early look at unusual or unexpected adverse events which come to the attention of healthcare providers which are requesting assistance with the review. Next slide. So shortly after vaccine becomes available, if the projections that we anticipate materialize, we'll begin to accumulate substantial data in our large link database monitoring systems, many of which we conduct near real-time sequential monitoring or rapid cycle analysis. This includes the CDC's Vaccine Safety Data Link, the FDA surveillance programs like their collaboration with CMS and BEST and PRISM, the VA Electronic Health Record and Data Warehouse, the Department of Defense Defense Medical Surveillance System, and then later on I'm going to describe this new initiative with Genesis. Next slide. This is just a table describing these systems in a little more detail to include the population and whether there is coverage for healthcare workers or long-term care facility residents. So VAERS, which is our system that monitors safety in the general population, and to include also NHS and acute care and long-term care facilities, will have coverage on healthcare workers and long-term care facility residents. For VSafe, all COVID-19 vaccine recipients will be eligible to participate in VSafe, provided they have a smartphone and can access the surveys. We anticipate that a substantial number of healthcare workers will participate in VSafe. However, due to technical limitations and maybe even some physical limitations, there may be limited capture of long-term care facility residents in VSafe. Then we move on to these large link database systems, which at the top there you see the Vaccine Safety Data Link. That includes insured patients in the VSD sites. There are a substantial number of healthcare workers in these VSD sites. Some of these sites are large Kaiser programs. There is also a substantial number of adults 65 and older in VSD. The ability to identify nursing home residents is challenging in these sites. So we think there may be limited visibility on long-term care facility residents. For the FDA CMS collaboration, this is 90+% of older adults in the U.S., including 650,000 long-term care facility residents, which they can identify and monitor separately from the community dwelling older adults. There may be limited healthcare workers just due to the age demographics there, but definitely capture of long-term care facility residents. BEST and PRISM is similar patient populations to the VSD. The VA Electronic Health Record and Data Warehouse includes enrolled VA patients, so it's likely limited healthcare workers, but the VA does run their own nursing homes. It's a relatively small population, but these are captured as enrolled VA patients, and we will have information on them from the VA data sources. The Defense Medical Surveillance System primarily focuses on active duty military, and there's limited information on beneficiaries. So there will be substantial capture of healthcare workers and likely limited capture in long-term care facility residents. The Genesis healthcare data is a new collaboration. CDC is working with Brown University and NIH. The Genesis healthcare has electronic health record information on long-term care facility residents, of which there are approximately 35,000 long-stay residents. They currently are not capturing information on healthcare workers, although there's some discussions on that, but definitely capturing information on long-stay residents in their EHR. Next slide. This is more of a reference slide showing our systems broken down by routine or established or traditional systems on the left side there, and then new systems on the right. And then on the top, systems are used for signal detection, and then on the bottom, systems used for signal assessment. You'll see there is overlap between signal detection and signal assessment. For example, we do rapid cycle analysis in VSD, and we also go in and assess signals in VSD as well. Next slide. So now I'm going to get a little more specific on safety monitoring in long-term care facility residents. Next slide. But I want to mention that VAERS is the nation's early warning system for vaccine safety, and will be the system that captures information on long-term care facility residents the quickest, and will provide data, the quickest data for CDC and FDA on safety in this particular demographic. Next slide. Again, VAERS has all U.S. residents as a covered population, all ages, races, occupations, including healthcare workers, healthy people, those with chronic conditions, those in long-term care facilities, and older adults living in the community. Next slide. The VA Adverse Drug Event Reporting System, which I previously mentioned, that's the VA's spontaneous reporting system. Although VA healthcare workers may not be enrolled VA patients, many of them are vaccinated in occupational health at the VA and are eligible or will be eligible to be captured by the VA aiders. It also includes the 8,000 residents per day in VA long-term care facilities. And as you see on the right there from this VHA directive from 2020, by policy, reports, vaccine adverse event reports captured in the VA aiders are reported to VAERS. Next slide. So this is a screenshot of the language for the adverse event module for the National Healthcare Safety Network. There is another screenshot which I didn't include because it would have made them so small, which shows the capture of doses administered, and that's basically a weekly count of doses administered by product type. And what you see here, actually let me back up, there are roughly 17,000 long-term care facilities in NHSN. And what you see here is a shot of the language for the adverse event module. It includes aggregate voluntary reporting of vaccine doses administered and counts of non-specific adverse events. So you can see there in section 5, you'll have weekly counts of adverse events. But I think importantly, it has guidance on reporting adverse events to VAERS, which you see circled there at the top in red, with a link to the VAERS website where you can report electronically, and also instructions to include the NHSN org ID number in box 26, which allows us, basically that's coding NHSN reports by site and allows CDC to do queries and identify those reports that originate from NHSN sites. Next slide. So Dr. Dooling previously mentioned the Pharmacy Partnership Program for long-term care facility vaccination. Her capture is a little bit higher than mine, and maybe I'm working off older data, but pharmacy partners may vaccinate a substantial percentage of may vaccinate in a substantial percentage of long-term care facilities. And this can provide early denominator information in long-term care facility residents, which can improve the accuracy of reporting rate estimates. And we have outreach to pharmacy partners on VAERS reporting planned. Next slide. So I want to run through a rapid cycle analysis in older adults in the systems which are going to do rapid cycle analysis. First, I'll talk about FDA's RCA and the CMS data. Again, this is about 92% of the U.S. elderly, including 650,000 long-term care facility residents. The data will be refreshed weekly with weekly sequential analyses. I'll just remind you that just because the data are refreshed and we do the analyses, that's a separate issue from the data actually accumulating. And for CMS fee-for-service, the average data lag is around 4 weeks, and the average data lag can be up to 5 to 6 weeks for hospitalizations. Then in the VA electronic health record and data warehouse, historically 60% of VA patients who get flu vaccination are 65 years and older, and that translates into about 1.56 million older adults vaccinated for flu annually in recent years. There are also 8,000 long-term care facility residents per day in the VA, captured in the VA EHR and data warehouse. The data will be refreshed weekly with weekly sequential analyses. I will say that that is part of the sort of the standard methodology that we've developed with the federal partners as far as the refreshes and the weekly and sequential analyses. And for the VA, there's an approximate 1 week average data lag and up to about 4 weeks for hospitalization. Next slide. Then for CDC rapid psych analysis and the vaccine safety data link, there are about 1.8 million older adults in 9 integrated healthcare systems that comprise the vaccine safety data link. Again, the data are refreshed weekly with weekly sequential analysis. There's an approximate 1 to 2 week average data lag and up to around 6 weeks for hospitalization. We'll say the data lag for hospitalization for these systems is mostly due to the hospital stay. So these are average lags when we go back and look at large volumes of data. Certainly some hospitalizations are longer than others, some shorter than others. The average is around 6 weeks, and that's mostly due to the length of stay. Once the patient is discharged, the processing of the data and that getting into the database for these systems is fairly rapid. Again, that lag is mostly due to the length of hospital stay, which can vary. Next slide. So we also plan to do case evaluations of adverse events. And some of our planned activities are rapid processing and review of reports to VAERS classified as serious for adverse events of special interest. FDA reviews all reports that are classified as serious, and CDC will be reviewing a selected list of adverse events of special interest, where we're going to review the reports and accompanying medical records. The processing times for COVID-19 will be 1 day for death reports, 3 days for serious reports, and 5 days for non-serious reports. We also plan to do investigation of clusters of clinically serious adverse events by a multidisciplinary CDC team if necessary, and clinical case reviews by the CDC's Clinical Immunization Safety Assessment Project. Next slide. Moving on to coordination, communication, and implementation. Next slide. So I want to mention the ACIP COVID-19 Vaccine Safety Technical Subgroup, otherwise known as VAST. The VAST was built off lessons learned from H1N1. The terms of reference and composition are finalized, and the VAST is ready to begin reviewing data once implementation commences. It's co-chaired by an ACIP member and an NVAC member. It has ACIP and NVAC representation, includes independent expert consultants, federal agency ex officio members, and liaisons from VA and DOD. Next slide. The objectives, the post-implementation objectives of VAS are to review, evaluate, and interpret post-authorization or approval COVID-19 vaccine safety data, to serve as a central hub for technical subject matter experts from federal agencies conducting safety monitoring, to share safety surveillance data, to advise on analyses, interpretation, and data presentation, and to liaise with the ACIP COVID-19 vaccines work group on issues of safety data presentation to the ACIP and application of safety data to policy decisions. Next slide. So I want to mention that we are ramping up our communications efforts in anticipation of vaccine becoming available. We will be stepping it up in the coming weeks as we anticipate that vaccine will be distributed and be available and be administered in priority groups. And this includes distributing communication materials to state health officials, healthcare providers, and healthcare systems, providing up-to-date information on the website, and conducting ongoing partner outreach and engagement to raise awareness of VSafe and VAERS reporting requirements, to include healthcare provider, professional organizations, public health partners, healthcare organizations, and other private sector partners, long-term care partners, and pharmacy partners. Next slide. So in summary, early data on COVID-19 vaccine safety in healthcare workers will mainly be available through VSafe and VAERS and systems that report into VAERS. Early data on safety in long-term care facility residents will mainly be available through VAERS and systems that report to VAERS. VAERS is a long-standing established safety monitoring system that is critical to monitoring new vaccines during the early uptake period. I'll also mention it's critical to monitoring flu vaccine every season when 150 million or so doses are administered in a very compressed time window of several months. Large link database monitoring systems will provide safety data when vaccines become more widely available in priority groups and in the general population. And efforts are ongoing to increase awareness and provide information needed to partners for safety monitoring. Next slide. So I want to reassure the ACIP, our public health and healthcare providers, and the public that we have the systems in place to collect safety data. We have validated methods to rapidly analyze the data. We have processes in place to respond to safety signals when we detect them. And we have trusted partners that we will depend on when we implement the vaccination program. Now, we have many important partners, but I want to specifically ask our public health and healthcare provider partners to help us over the coming weeks and months. And for our public health partners, we ask that you promote participation in VSafe. It is a manual enrollment process, and it will involve interaction with the patient to inform them of VSafe and inform them of the importance of VSafe. And we are asking your participation to help promote VSafe. Also promoting reporting to VAERS and communicating with your partners on vaccine safety. And then for healthcare providers, we're asking you to encourage patient participation in VSafe, to report adverse events to VAERS, and communicate with patients on safety. Next slide. And this is a reference slide with information on how to report to VAERS, how to contact CDC through CDC info, and some other safety information resources. Next slide. Thanks, and I'll be happy to address questions.
Thank you very much for that very detailed and in-depth discussion. Before we move on to discussion and questions, I believe Dr. Messlinier has something to say.
Yeah, thank you, Dr. Romero. I just want to reiterate the importance that CDC places on the safety of vaccines. I know that FDA will not authorize a vaccine and ACIP will not recommend a vaccine unless you're convinced, based on the phase 3 clinical trials, that the vaccines are very safe. But we all also know that vaccine safety doesn't stop there, and especially for these vaccines, we're going to hold ourselves to an exceedingly high standard for safety monitoring after a vaccine is authorized and when it's rolled out more broadly. Tom Shimabukuro and his team, and frankly, a vast array of scientists across the U.S. government and among our partners have done an incredible job of enhancing our existing vaccine safety systems to really meet this challenge. And I think they've done a great job of trying to anticipate any gaps in the system and fill them. But as Dr. Shimabukuro says, our vaccine safety systems are partly dependent on the stakeholders in the health systems, the public health departments, and frankly, the public reporting adverse events. So we do need to ask, especially in this initial phase, for everybody in the community to be rowing together. It may mean extra work for some groups where they have to report through other systems as well as through these systems, but we really need to ask everybody to be mindful of this early phase and the importance of this data. And I think that we really need to call on the entire community to help us ensure the safety of these vaccines. Thank you.
Thank you. We'll now open this up for discussion. So, Dr. Sanchez, you're up first on the list.
Sorry, that was from before.
Very good. Thank you very much. Dr. Alt.
I had a question kind of emphasizing the previous point there. What can we do, or what has been proposed to do, to encourage people to be involved in the Be Safe program, since that seems to be the quickest way that we're going to get safety data?
Well, we are ramping up our communications efforts to get the message out to our public health partners and to the provider community and to other partners like pharmacy partners about the importance of VSafe in capturing early information on vaccine safety. And we're reaching that time where we're really going to be pushing out strongly and trying to get the message out as broadly as possible to those who are vaccinating or those who partner with those who vaccinate. So this mostly involves reaching out to partner organizations, professional societies, public health partners, pharmacy partners, and others who are going to be directly involved in vaccination.
And this is Amanda. I just will add another plug. This health system and healthcare provider toolkit, communications toolkit, will include information about how to enroll patients in VSafe and information about the program and tips for encouraging patients to enroll.
Our next speaker would be Dr. Paling, please.
Yes, this is Kathy Paling. And so first of all, Dr. Shimabukuro, thank you for a really important conversation in highlighting the importance of the initial assessment of safety as well as following the safety of all vaccines that are being administered. This is incredibly important. I wanted to give you a chance to provide a little bit more information about VSafe and how that data will be monitored and the confidentiality of reporting through this system. Thank you.
So operationally, how VSafe works is that an information sheet, which will be available probably in different formats, includes a URL and a scannable QR code, and the individual patient enrolls themselves by either typing in the URL or scanning it, and it takes them to a registration site. And there's a limited amount of information a person puts in to register. Then you have a confirmation step. Then you have to enter your vaccine. And once you're registered, it kicks off this process of basically the CDC sending messages with a link, a web link, and then that link takes you to an electronic survey. And for the first week of vaccination, we do daily check-ins where we ask about local and systemic reactogenicity and also some health impact questions. The local and systemic reactogenicity questions and some other questions, those are fed into a database that has all the federal IT security and privacy protections. That information is available to the CDC folks who are doing the safety monitoring. For those who have a health impact question, we are going to actually use the cell phone numbers from the registration to reach out to them and take a VAERS report. So that report will actually get into VAERS, and the VAERS is our public health, our spontaneous reporting system, which basically is subject to all the security requirements and HIPAA as well. So I think patients should be vaccinated individuals should be confident that private information will be protected and that it will be used for safety monitoring purposes only. Do you have any other follow-up or any other additional information you want? And that will be reviewed. That will be reviewed and presented to the vaccine safety technical subgroup regularly, and analyzed in the context of signal detection.
Thank you. That is incredibly helpful, and I appreciate that clarification.
Dr. Zahn.
Thank you. Can you hear me?
Yes, we can.
Yeah. Okay. Thank you, Dr. Shimabukuro, for that presentation. So, as a local public health person, I think we'll be extremely enthusiastic to get out information about the need to report. Because a couple of comments I'd have. One is that you just like the general message to be, if something happens to you or your patients, report it. If you have an issue, report it. I think the fact that you have to use a smartphone, it sounds like in order to use vSafe, complicates the message a bit. I know that there's only so much you can do in a very short period of time, but that does complicate it a bit. And I guess the other one thing in terms of messaging that I think is going to be very important for us is for providers. They're going to hear about vSafe and they're going to hear about VAERS, and which system do you use for which situations, and what do you tell your patients to report versus what we report through VAERS. Clarifying that, it seems to me, is kind of really important. And then just one last question is, I think you mentioned that, and maybe I misunderstood this, that you were going to be conducting outreach to pharmacies and pharmacists regarding adverse events and the reporting in the context of vaccinating in long-term care facilities. And maybe I misunderstood that, but in that scenario, I'd think of it as that they're going to go out and they're going to think the responsibility I have is to vaccinate, but over time, the people who are caring for them at their facility or their primary care provider are the ones who are really going to be identifying and reporting those issues. And so it seems to me it's really, really important, I'm sure you're going to do this, but to communicate also to skilled nursing facilities or long-term care facility staff, this is how you are supposed to report, these events. Obviously, NHSN is one resource, but those are just comments. Thank you.
Thanks. Actually, you brought up a good point that I think needs clarification and probably better explanation in our communication material. So vSafe is really an interaction between the patient and CDC, and they're reporting information to us. When you get beyond the first week where we're looking at local and systemic reactogenicity, the patient is actually reporting to us a health impact. They're answering some health impact questions, and those questions, I don't know if this is the exact wording, but it's three things. Did you miss work? Were you unable to do certain daily activities? Or did you seek health care or get health care? If any one of those is checked, then that triggers active telephone follow-up with that patient where we do an assessment. And if the patient or the patient's provider has not already submitted a VAERS report, we would take a VAERS report over the phone. Their reporting is not really to VAERS. It's more us doing an assessment of a health impact and reaching out and getting a report. And I just wanted to make that clarification. And then I think brought up a good point that our message to providers is we encourage, in addition to the EUA reporting requirements, we encourage reporting of any clinically significant adverse health event, even if you aren't sure if the vaccine caused it. And that would be irrespective of whether the person's enrolled in VSafe or not. If it so happens that 2 reports get in there, we have ways of identifying those and consolidating the reports.
Thank you. Dr. Foster.
Thank you. This is, first of all, thank you for all the presentations and especially all the enormous effort that has gone into the planning for this. Matt just brought up a very good point, which I want to kind of reemphasize again, is that the fact that pharmacists will be, for the long-term care facility portion of it, will actually be going to the facilities and then will in turn be there for a day and separated out by whatever length it is. And I think it's going to be 3 to 4 weeks between visits and then back. So has there been a mechanism built into it for the reporting at these nursing homes in between? Are they going to report back to the pharmacist? Are they going to actually take care of the reporting themselves? Because that may be a gap right there.
So, I mean, based on your comments and Dr. Zahn's comments, we probably need to revise that. And maybe it's awareness for our providers, but the awareness for our pharmacy partners, but really the specific guidance on adverse event reporting needs to be targeted to the healthcare providers that are going to be interacting with these patients on a daily basis following immunization.
Thank you. Dr. Maldonado.
Yeah, thank you very much. This is a great overview and really helps put a lot of the safety tracking into context. But I'm still struggling just a bit with all of the different systems. Obviously, the old and current systems I think we're pretty aware of, but I'm still struggling a bit with some of the workflow streams for some of the new systems. For example, on slide 9 specifically, I'm trying to figure out, I don't know if we can go back to slide 9, but if we can take a look at the different, on the right-hand side, there are a number of systems. I think it'll be helpful, as you heard before, to clarify how the signal detection systems will be introduced to the general population as well as to the healthcare workers who are already going to be struggling to try to understand who to vaccinate and how to see operations. But I'm struggling in particular with the signal assessments and why I don't see VAST there, or where does VAST belong in all of this? Because it seemed to me that was introduced as a signal assessment, or maybe I'm misinterpreting that.
You're referring to the vaccine safety technical subgroup?
Yeah, so it's not, I mean, is that an assessment platform as well? Or not?
Well, I would consider that the VAST is more of that's a group of external experts, which, and in that forum, that's really the central hub for the federal agencies that are doing the monitoring in these systems to go report to our external experts and get feedback on data interpretation and analysis and maybe even further signal assessment. This slide is really a systems-based slide. So, for example, we do rapid cycle analysis in the vaccine safety data link. If we detect an RCA signal, we would go into the vaccine safety data link and further assess that signal, or possibly even engage with our FDA colleagues to see if they could do further signal assessment in the CMS data. The VAST is the group where we would be in contact. We would be in contact with VAST and meeting regularly and presenting data from these systems on our signal detection and our signal assessment and getting feedback from them. So this is more of a systems-based slide where I think that is more of a process, maybe a signal assessment process. Does that make sense?
Yes, I guess I'm still struggling to understand where, so let's just say you find assessments. At what point are actions taken? Well, I guess they would be outside of the systems and the platforms then, or there would be other
Well, if you're saying if we detect a signal and we verify it and we establish that there is a risk,
right?
I mean, by that time, I think the VAST and the ACIP COVID-19 work group and the ACIP would be involved in the process and would be in receipt of this information, and there would be discussion and potentially some type of policy decision which might involve public health or regulatory action if necessary. But that's like a separate process from it's intimately linked what the VAST is going to do, but this is more of a systems-based data analysis process that I'm describing on this slide.
And the reason I bring it up is not only is again all of the stuff on the right-hand side of the slide is really important, but there's a lot for people to digest there. But also, if there needs to, I'm thinking back to RotaShield back in 1999. How quickly, if you get, that was rapid cycle. Well, it was pre-rapid cycle, but essentially it was similar to a rapid cycle analysis. But if you detect a signal in vaccine X, how will it inform not only vaccine X, but vaccine Y, Z, and beyond that are coming down the pike? I mean, I think would those go back to FDA? I mean, how are those processes going to work? Because that's really, I think it's helpful to track, but you want to know how will actions be taken to address, and how will these signals be prioritized? So what are the different options? And I get that it's vague and that we don't know what we don't know, but it would be helpful to see, a separate maybe algorithm around how will actions be taken based on signals that are detected not only for this product, but for products coming down the line from the FDA, for example.
Dr. Maldonado, this is Amanda. I think what you're asking for is more of what happens when a signal is detected. And the first step would be signal assessment, and then the role of VAST would be to interpret the data and to and understand the data and provide advice to the ACIP on that. What I can say is that I think that during the next ACIP meeting in a couple of weeks, we can delineate more the step-by-step process of what we will do if there is a signal. And we do anticipate that there will be signals that need to be assessed because of the populations in particular, as all of you have discussed. We anticipate that there will be signals among older adults that will need to be assessed, which are unlikely or may or may not be causal and related to the vaccine. There will be many more signals than there will be actual adverse events that need to be assessed. So we can present that at the next meeting.
Great, thank you.
Dr. Lee.
Thank you. And actually, I was just going to pick up where Amanda left off. So Bob Hopkins and I co-chair VAST, and the goal is to review the data from all of these systems as it's coming in. And I think Dr. Shimabukuro outlined nicely that the timing of the availability of the data will likely be staggered. However, the plan is for that data to be reviewed on a regular basis, at least weekly at this point, pending the availability of data. So we anticipate that the Vaccine Safety Technical Subgroup, which reports to the ACIP COVID vaccines work group, will do so on a regular basis, and that information through the ACIP COVID vaccines work group will be brought forth to ACIP. And agree very much that it would be helpful for us to present the processes that are in place for that, the framework for evaluating signals, which is signal detection, signal refinement, and signal evaluation. So we can definitely bring that forward next time, and following, similar to what was done during H1N1. So we anticipate a robust process. I just did want to comment on the terrific comments that were brought up by the prior speakers. So the way I think about, there's a lot of safety systems available, but the way I think about it, and I'm thinking about this right now from a healthcare provider perspective, is that VSafe really focuses on individual patients. And our role as healthcare providers are to, support and facilitate vaccinees to enroll in VSafe so that they can self-report what is going on post-vaccination. And I think Dr. Shimabukuro gave a lot of wonderful detail about what is included in that system, but that is really a patient-directed system. In addition, the goal is to ensure that all healthcare providers are aware of how to report into VAERS any potential adverse events that may occur. And so that would be something that we would ask providers to engage in and report into. And again, VAERS is co-managed by CDC and FDA, but that would be specific to providers and asking them to take action. And then I think the third layer that's important to highlight is the National Healthcare Safety Network. And this is a national safety surveillance network that's been in place for decades. 4,700 acute care facilities and 17,000 long-term care facilities in the U.S. are NHSN users. And so I do think that it's going to be important for us to encourage also facility level reporting. So different from patient level reporting and different from provider level reporting, but facility level reporting that encourages acute care facilities and long-term care facilities to support efforts to report not only doses administered, which is in the COVID vaccine module that's forthcoming, but also any clinically significant safety events that occur. And that, I think, would address some of the questions and issues that were raised earlier regarding the connection between long-term care facilities and pharmacies. Recognizing, again, that those systems are coming online, and we anticipate for the acute care facilities it'll be sooner rather than compared to the long-term care facilities. But sharing this aggregate information with NHSN will be incredibly helpful. And linking it to VAERS, which is what Tom presented, will be also incredibly helpful for the safety monitoring system. But each of the systems is really targeted at a different level, and hopefully we can clarify, those of us who are in healthcare systems, how we can use at the facility level NHSN for reporting. Those of us who are practicing and seeing individual patients, how we can use VAERS to report. And then specifically VSafe, ensuring that we're educating patients who are getting vaccinated and how they can also self-report. So hopefully between those three levels, we will have many opportunities to continue to support vaccine safety monitoring in the U.S. Thank you.
Thank you very much. Dr. Talbot.
So our pediatric colleagues are very well versed with VAERS, but I don't think our adult colleagues are quite as well. I think our family practice physicians are because they span the gap, but internists and geriatricians rarely have any knowledge about VAERS. And what concerns me is that the people who work at long-term care facilities are not actually represented around the circle. There is the American Geriatric Society, but there is not the American Medical Directors Association. So I have two questions. One, what has been done to reach out to other groups that are not just liaisons? And two, how many VAERS reports have actually been put in from long-term care facilities in the last year?
I know that our communications folks are planning substantial outreach to partners, including long-term care partners and geriatric care partners, also OBGYNs and other vaccinators. So I mean, we certainly recognize that we need to get the word out as rapidly and as broadly as possible on the importance of the availability of VAERS and on the importance of VAERS reporting. As far as how many have come from long-term care facilities, I don't have the answer to that. That is captured on the VAERS form. It's more. I think the category is more combined, so it could be long-term care facility and these community living facilities for older adults. So you may not be able to split it out, but that is something that we can look at. But I don't have the numbers for that. We'd also have to probably look at that by vaccine or vaccine type as well.
Hi, this is Dr. Dooling. I just wanted to add that all of those important constituents who will need to be plugged into VAERS to ensure its success for this program, many of them are represented as liaisons on the COVID work group, and we will continue to inform them and have them inform their liaison constituents.
Thank you. Dr. Bernstein.
Thank you. An amazing presentation, Tom. I don't consider myself technologically savvy, but I was wondering if the CDC can work with cell phone carriers to have vSafe offered for download now, sort of the way updates are made for software, and then practice teaching examples could be created so vaccine recipients in the near future, can begin to learn about vSafe and hit the ground running for their own individual safety monitoring after being vaccinated.
I may be even less technically savvy than you, so I'm reluctant to give you a straight answer, but I will take that back to our technical experts at vSafe and see what they think about that.
Are there any other comments? I think I don't see any. I'll end this, I think, with this one comment which I think goes without saying, that in educating the public regarding these vaccine safety systems, it's going to be very important that we provide culturally and linguistically appropriate information to the general public so that they understand what this is all about and they enter data as appropriate. I really stress this going forward if we really want to capture all signals that could arise in the use of these vaccines. So if there are no, I see one more comment by Dr. Hayes, and then we'll have to move to the next area. Dr. Hayes.
Thank you. Carol Hayes with the American College of Nurse Midwives. So I have two questions. One is the working group, I would like to make suggestions for organizations that are not liaisons that I want to make sure that we communicate with, and I don't know who should I send that contact information to. And my second question had to do with the translating the app into multiple languages, so not just English. And so I just wanted to ask if there was plans to do that. Also with the consent forms, how many languages is the intent to translate them into? Thank you.
This is Tom. I just want to clarify that the vSafe program is not an app, like an app on your phone. It's actually a text messaging program where you get a text message and there's a link to a survey in there. But the text messages and the surveys, there's a plan to translate those into the I don't know how many it is, but the top so many languages that CDC does these translations for. And so there's the plan to do that. The first one that we're going to work on is Spanish. We want that one available quickly. And for the other materials, I'll have to defer to others on the line.
This is Dr. Cohen. There are 5 languages that we will translate this along with other CDC products into. I also want to assure everyone that we have 30 liaison organizations to ACIP. We have hundreds of partners that we need to engage and listen to and educate and talk to about all of this. And so we have very strong partnerships across the healthcare sector through that have really been solidified over the past year with the pandemic, and we will ensure that we do extensive outreach beyond the ACIP community. And we will also ensure that we absolutely take the advice and understand the importance of ensuring that our outreach materials, both to healthcare providers who are being recommended to get vaccinated, as well as to individuals to ensure that the communication materials are culturally appropriate and at a reading level that is accessible to across the educational background of the healthcare community.
Thank you for that. Dr. Zahn, your hand is up. I'm not sure if it's a residual from earlier.
Yeah, no, I just need to pull it down. Thanks.
Thank you very much. All right. So shall we move on then to discussion and a motion for vote?
Dr. Romero,
yes, Dr. Cohen, you want? Yes, go ahead, please.
We are pulling up the language that we'd like for ACIP to consider making a motion on.
Yes. Yes.
So it'll be here in just a minute.
Thank you, Dr. Romero. So we've seen the evidence. We've had some very detailed discussions of clinical considerations and safety in the rollout of a future COVID vaccine. And now I'd like the members to take a step back and look once again at the policy question at hand, which is, should healthcare personnel and residents of long-term care facilities be offered COVID-19 vaccination in phase 1? And here,
phase 1A?
Phase 1A, yes. And here is the interim recommendation language. When a COVID-19 vaccine is authorized by FDA and recommended by ACIP, healthcare personnel and residents of long-term care facilities should be offered vaccination in the initial phase of the COVID-19 vaccination program, phase 1A. For your convenience, I've provided definitions of the groups that are contained within the recommendation language. And Dr. Romero, I'll turn it over to you.
Thank you very much. So this is open for discussion and further clarification. Let me begin by asking this question, just to be certain that everyone understands that the listing of the order, that is healthcare personnel and residents of long-term care facilities, their listing implies no preferential order of vaccination. Is that correct, Dr. Dooley?
That's correct. That's the intent of the work group.
Very good. Dr. Paling, please.
This is Kathy Paling, and so I wanted to say thank you to all who've done great presentations to provide insight on this, and I'd like to take a moment to make a motion to approve this wording.
Does anybody else wish to offer comment before we move to the vote to the approval of the motion? I believe Dr. Kimberlin's hand is up. Did you wish to make further comment, Dr. Kimberlin?
Yes, David Kimberlin, AAP Red Book. I asked at the November 23rd ACIP meeting for confirmation that people who work in long-term care facilities are considered healthcare personnel. I don't know that needs to, and I was told yes, that is the case. I'd just like at least a verbal confirmation of that, if not actually putting them in one of the little sub bullets there to explain that more directly.
Dr. Doolin, do you want to comment? Or?
Yes, I can confirm that long-term care facility staff are included as healthcare personnel as under the definition that you see in front of you, and the details including that group will be included in a future MMWR. And other groups such as EMS, community health, et cetera, will be detailed in greater detail.
Thank you. Dr. Alt?
Dr. Romero, I would just, can we get a second before we start the discussion?
Okay.
Just to follow.
That's fine.
That was actually why I had my hand raised.
Thank you, Dr. Alt.
I was going to second.
All right. So we have a second. We have a first second. Okay. Shall we continue the discussion? Dr. Maldonado.
Yeah, I'm sorry I forgot to ask this before, but it just seems so obvious now, but I assume you're talking about medical long-term care facilities and not congregate living facilities such as prisons, detention centers, et cetera, or what happens if there are long-term care medical facilities that are detention centers, prisons, et cetera? Those are not included here?
The long-term care definition that we're going by, which is listed, really refers to facilities that are providing medical and personal care. Occasionally, those are provided within a corrections facility, and those would count.
Thank you. Dr. Atmar?
Thank you, Dr. Romero. So I have no issue with the healthcare personnel. I remain a bit concerned about including residents of long-term care facilities in the 1A group because of the lack of both safety and efficacy data in that patient population. I am somewhat persuaded by the support of the AGA and others and the information provided about the ease of administration at the same time to the resident population as vaccinations being provided to the healthcare personnel working in that area. I'm a little bit concerned about the issue that Dr. Talbot raised about the safety reporting. I know that plans are in place to do the monitoring, but there is the potential for a lag of information arriving, and it'll be particularly important that, as is planned, the long-term care facility be asked to vigorously participate in the VAERS program. Staffing to do that may be a bit of an issue, and I'm still worried about this group, although I'm leaning towards including it. I still have concerns. Over.
Sorry, thank you. Dr. Hunter.
I'm very strongly supportive of the interim recommendation as written here. I wanted to just make a comment that I'm assuming that the sub-prioritization that we discussed earlier will be captured in guidance that's written as part of the publication of this vote in the MMWR, and I'm just curious how soon that might be available to the especially healthcare systems that are going to be needing that to do the prioritizations. Thanks.
Thank you.
Dr. Hunter, this is Dr. Oliver. I can clarify that. So several of the clinical considerations, including sub-prioritization that were discussed earlier today, will be summarized and posted on the CDC website, the ACIP website, under the recommendation, including the healthcare personnel and long-term care facility information.
Thank you.
Thank you. Dr. Howell.
Hi, Molly Howell with the Association of Immunization Managers. A couple of comments. One, I just wanted to let you know that we did survey our 64 members as to whether or not they would like to see long-term care residents included in phase 1A with healthcare workers. And it was a short turnaround, so we only had 19 responses. However, 14 responded yes, they would like long-term care residents included in phase 1A. Mostly for logistical reasons, and then also concerns about uptake of COVID vaccination amongst staff in long-term care. The one question or clarification that would be helpful is regarding the definition of long-term care facilities. It was previously, I think a lot of us have been planning for skilled and assisted living. And after today's meeting, I'm getting the impression that it also may include group homes. And then it was just mentioned it might also include corrections. And then now I'm also wondering about homeless shelters. And so if additional clarification could be provided on the definition of long-term care, that would be helpful.
Hi, this is Dr. Dooling. I can clarify. So long-term care facilities were primarily focusing on skilled nursing facility and assisted living, with an implied priority for skilled nursing facilities first, and moving on to assisted living as vaccine supply dictates. And it's understood that, as we mentioned previously, that gating criteria will be needed to move from one phase to the next. And so as shown previously, it's possible that we may be working on assisted living as we move into other phases.
Thank you. Dr. Sanchez.
Thanks, Jose. Just a little bit of just the wording. Technically, as stated, healthcare personnel and residents of long-term facilities, that, as worded, would say that it's the healthcare personnel of the long-term facilities. So I think those two need to be separate. It's just a matter of wording. I think one is healthcare facilities and two are residents of long-term healthcare personnel and two are residents of long-term care facilities. That's a matter of wordsmithing. I don't want to get into specifics, but as you read it, it implies that it could be just healthcare personnel of long-term care facilities.
Thank you. We'll clarify that.
Thank you. Dr. Szilagyi?
Yes, I just wanted to express my strong support for this interim recommendation, including both healthcare personnel and residents of long-term care facilities. For me, the incredible high risk of the latter group, the residents of long-term care facilities, and the very careful safety monitoring. To me, I know there's some concern or there was comment that the modeling studies suggest that vaccinating healthcare personnel around them is more effective. I believe I'm sure that's true, but if we could add more protection by vaccinating the residents, that really swayed me. So it really has to do with an issue of safety, and I was very impressed with the safety monitoring systems that are being designed. So, and I'm also want to emphasize that the transparency with consent and assent in the long-term care facilities will be really important, and that swayed it for me. So I express strong support for this recommendation.
Thank you. Ms. Bata.
Thank you. I too wanted to just echo my support of this interim recommendation and to thank the work group and the CDC leads for such a well plotted out process that you have taken us through to get us to this point. Thank you.
Thank you. Dr. Hahn.
Hey, thank you. Christine Hahn from CSTE. I just have sort of a practical question as an implication of this. My understanding is, as we've discussed, most long-term care facility residents and potentially workers would be vaccinated through that through the pharmacy contract. And my understanding from our immunization program is that it takes 2 weeks for the state to sort of request that process to start and be sort of turned on. And I know the vaccine isn't in our doorstep today, but is there a possibility that we'll be a little bit hamstrung by a delay in getting that vaccination started, and that states will struggle to implement this recommendation when there's some sort of a delay in getting that long-term care facility? I just wanted to, somebody could just address that from just a practical standpoint of trying to be fair in getting this started so that healthcare workers and long-term care residents are being offered vaccination if the intent is about the same time, how that might look.
This is Dr. Cohn. I can respond. The intent of this vote today is to provide guidance and recommendations for health departments to go ahead and place their orders for COVID-19 vaccine and determine how they want to take this guidance and implement it at the state and local level. So we anticipate in terms of being able to turn on a pharmacy program for long-term care facility residents, that if a state chooses to do that in the first week or days of the program, that there would be enough time between the end of this week and vaccine availability. We do not anticipate substantial delays in that program, but it will be determined at the jurisdiction level how they put in their orders.
Thank you. Dr. Bernstein.
Thank you, Dr. Romero. My decision to include the healthcare personnel in Phase 1A was straightforward. In contrast, the decision to include long-term care facility residents was initially a challenging one for me, especially when vaccine supply is initially constrained. Coupled with controlling resident direct contact with outside visitors and use of appropriate mitigation, I was thinking that only vaccinating staff was likely to notably minimize coronavirus exposure to long-term care facility residents. However, reflecting further on the data that has been presented over the last several weeks and months actually, has moved me to change my thinking on long-term care facility residents. In particular, long-term care facility residents and staff account for 6% of COVID cases and 40% of the deaths in the United States. A majority of the COVID-related hospitalizations in those 75 years and older have been from long-term care facilities. The systemic reactogenicity of the vaccine in a relatively small number of older adults appeared lower among the older age population in Phase 1 and Phase 2 trials, although long-term care facility populations were not included. And while vaccination should be strongly encouraged, it is likely that vaccine uptake among long-term care facility staff will vary considerably, which is not ideal for limiting resident exposure. And lastly, there are federal pharmacy partners in place to help implement long-term care facility programs for residents. So for all these reasons, I am in support of this policy question.
Thank you. Dr. Talbot.
So I have really struggled with this, and y'all have heard me struggle throughout these meetings. I have spent my career studying vaccines in older adults, and we have traditionally tried a vaccine in a young, healthy population and then hoped it worked in our frail older adults. And so we enter this realm of we hope it works and we hope it's safe, and that concerns me on many levels. Particularly for this vaccine, my concern is there is less reactogenicity, which also means there's less immunogenicity. Two, I do not feel like our safety network for long-term care facilities is strong enough yet. I think there's some work that needs to be done. And three, if we're going to spend the time to educate anyone, I think the workers are going to be incredibly important to vaccinate. We know with flu that there's little impact on vaccinating residents, but huge impact on vaccinating the healthcare workers. So I'm still struggling, and I'm really struggling since we don't have a good safety surveillance network in place. Over.
Thank you, Dr. Talbot. I see some hands are up, and I'm just going to run through to make sure that they're either residual or I didn't skip somebody. So, Dr. Hunter, your hand is still up. Do you wish to make another comment?
Sorry, no.
Dr. Bata, I'm sorry, Ms. Bata, your hand is up.
Sorry.
No need to apologize. I'm simply making sure that everybody has an opportunity to have their say. Dr. Hahn, your hand is still up.
Sorry, I'll take it down.
No. Again, no apology needed. Dr. Fry, your hand is new, so please go ahead.
I also just wanted to weigh in, but briefly, I have to say that I am in favor of this Group 1A as it is currently categorized with health care workers and people living in long-term care facilities. I think it's crucial to maintain our health care capacity and but also for vaccinating healthcare workers, but it's also important to prevent severe disease and death in the group that is at highest risk of those complications, and that includes the people in the long-term care facilities. I have to say that I was less concerned about risk early on in folks in the long-term care facilities because typically we see lesser immune responses in this group in general. But this is an unknown platform that we obviously are testing in thousands and thousands of people, and we do have a lot of good safety data at this time, post-second vaccination. But I still am a bit concerned about vaccinating this group, but I still think it's the appropriate thing to move forward and vaccinate the healthcare workers and folks in the long-term care facilities simultaneously in order to get the job done more quickly, but with keeping in mind safety and oversight of that safety at the same time. Thank you.
Thank you very much, Dr. Fry. I see no other hands up. Right, there are no other hands. So let me turn it over to Dr. Amanda Cohn, who has a comment or two before we take a break.
Thanks, everyone. I just want to lay out what will happen when we come back from about a 10-minute break. At about 5 p.m., we will begin the public comment session. We ask that the commenters respond to this recommendation for which ACIP will be voting on. After the public comment session, which we anticipate will take about 30 to 40 minutes, we will have the ACIP members, the voting members only, turn their videos on, and we will vote on the motion. After we go through the ACIP votes of the members, we will then allow each member the opportunity to indicate or make any comments related to their vote. Some of you have expressed have made comments already, but this will allow each ACIP member to make provide comment related to their vote. We anticipate that the meeting will be done at about 6 p.m. We apologize for it running late, but we appreciate the robust discussion.
Thank you, Dr. Cohn. So without more said, let us break until for 10 minutes. We will adjourn. We will reconvene at the hour on the hour. Excuse me. Thank you very much. 2 minutes before we start the public comment section. 2 minutes.
Dr. Romero, we are ready for you to begin the public comment session whenever you are.
Very good. All right. So we'll start our public comment section. At the outset, I'd like to welcome and thank our public comment speakers for addressing the committee today. Your comments and thoughts are extremely important to us, and I want to thank you for taking the time to do so. All the speakers today submitted a request in advance of the meeting, and the final list of public commenters was determined by a lottery. This comment is for the speakers. We have a limited public comment period, and in order to make it through all of the speakers, it's very, very important that each speaker limits his or her remarks to 3 minutes. There will be a display on your screens of the time, a circle that will go from green to red to indicate your time. As you proceed towards the end of your time, I will state, thank you for your comment. Your time is expired. If you exceed your time limit by 15 seconds, I will state, as a courtesy to other speakers, we ask that you conclude your comment. And if you prolong your talk for more than 30 seconds, then I will state that your comment time has ended, and thank you, and cut your microphone. So we'll begin with our first speaker, Ms. Hargrave. And please state your full name and your affiliation. Ms. Hargrave.
Thank you. My name is Allie Hargrave. I'm a working pediatric registered nurse in the state of Minnesota and a combat veteran of the United States Air Force. I am no stranger to witnessing vaccine injury. I came to this meeting to bring questions that, in my opinion, deserve to be answered before it can be deemed appropriate to distribute the fast-tracked COVID vaccine to frontline healthcare workers. Why are roughly 36% of nurses planning to refuse this vaccine and 31% of nurses unsure if they will take it? How do we know that there will be no long-term health consequences from receiving the COVID vaccine? Long-term injuries and ailments are a possibility from any pharmaceutical product. Therefore, it's questionable how the label of safe can be given to the COVID vaccine when long-term studies and monitoring have not been done. Is it possible that we will be sacrificing or risking widespread injury among our essential population of healthcare workers for this pandemic and potential future pandemics? What about paradoxical immune enhancement? You must remember the phenomenon that created lethal inflammation during the 2012 animal studies of previous coronavirus vaccine trials. When all the vaccinated ferrets were exposed to the natural infection, then died from the overly robust immune response. How can we possibly know that this will not occur again when animal trials were forfeited for the sake of an accelerated timeline? Again, is it possible we are risking our essential healthcare workers by not having these questions answered? And what about healthcare workers who have already recovered from the natural COVID infection? How will this vaccine act with the existing antibodies that they have? Is it safe to give this mRNA vaccine to people who have already recovered from the natural infection? Was this considered during the fast-track trials, especially considering how widespread the natural infection is amongst our healthcare workers? Finally, as a nurse, I'm legally bound to give informed consent prior to giving any medication or intervention. How will it be possible for me as a recipient to receive informed consent when the CDC website states that ingredients of the COVID vaccine may be withheld due to proprietary concerns and the phase 3 of the trials is still in progress? How can I receive informed consent without all the information available? With these questions, does it make sense for our frontline healthcare workers to receive this inadequately tested, liability-free vaccine when the nation is literally depending on them to guide us through this pandemic? How can you call yourself an advisory council when you don't have all of the adequate information to advise with? Thank you.
Thank you for your comments. Next speaker is Mrs. Ricardo. Please come forward.
My name is Ricardo, the República Oriental del Uruguay. I'm present the program last year and GIS present a new program, the intelligent artificial. The name is True Colors. Es una nueva óptica de ideas para put the end the coronavirus. The human body is a great universe and True Colors and searching new possibilities that put the end the coronavirus and other diseases. I had the nuevo tools and more efficient and vaccines in identify bacteria and more data and more possibilities for efficient, the harmful, the vacunas and the humans. I connection the Embajada of the United States and Uruguay and since 6 years old. Only question no problem. Communication. Excuse me, my English is very little. I present the United States new option in intelligence artificial put in the coronavirus and more bacteria. Así que thank you very much. In the United States, you order, sir.
Gracias por su comentario. Thank you very much. We will move forward. Next speaker is Dr. Foreman. Dr. Foreman?
Dr. Romero, I don't see him on the call right now.
Thank you very much, Stephanie. Let's move forward and then come back to see if Dr. Foreman comes on. Mrs. Anagnasto, and forgive me if I mispronounce your name.
That's no problem. Can you hear me?
We can. Please go forward.
My name is Sia Anagnastu, and I've worked for nearly a decade heading up corporate development at a company called Immunomic Therapeutics. So we work on nucleic acid vaccines, quite similar to the technologies that underlie the COVID vaccines being discussed today, but we're focused on things like allergy and cancer. I'm also a co-founder and board member of Why We Vaccinate. This is a nonprofit that is dedicated to supporting vaccine education, awareness, and countering vaccine misinformation. So I want to thank you all for having this meeting today and for your individual and collective hard work and dedication to support the use of vaccines in the U.S. I want to also note that amongst all the complications of this pandemic, the committee has been working to hold these meetings and be transparent and inclusive in your deliberations, and for the overall process for how you make these recommendations. I support that you continue being transparent and inclusive. I think it'll continue to, or at least try to instill confidence in the process and in COVID vaccines in general, which we know is so important. Also, as a mother of young children, I see one of the challenges to public confidence in vaccines, and I think we're seeing some of that today, or we might in a couple minutes, is the influence of people and groups that continue to spread misinformation and disinformation. You know, we haven't always taken it very seriously, but I think we continue to see the deleterious effects before just on general vaccine uptake that protect us all, but now with COVID, misinformation is going to cast new types of doubt, and you know we've been seeing it about the safety and effectiveness, and this is possibly going to be harmful to all Americans, and even the ones that we've been talking about today who are most vulnerable to COVID-19. So I think, you know, just in general, the motion put forward today obviously has been done with extensive deliberation and consultation. And it's a great first step to protecting Americans from COVID and for the safe and adequate operations of healthcare providers and services. So I strongly support voting for the motion. But also I want to encourage CDC to continue to conduct education activities and outreach and to be a trusted public source of information, because I think your credibility goes a long way to promote confidence in use of COVID vaccines. And I think we all need to try to directly address some of the concerns that Americans have about these vaccines, so that we can do our best to ensure widespread uptake, so we can all get back to normal life. So thank you all for the hard work that you do.
Thank you for your comments. Dr. Schmidt, please.
Thank you very much. My name is Harold Schmidt. I'm an assistant professor in the Department of Medical Ethics and Health Policy at the University of Pennsylvania. I'd like to start by congratulating the committee members and especially also the staff for their work. The complexity of data integration and the pressure, political and otherwise, is just intense, and I frankly have no idea how you do it, but evidently you do. All the best as the initial finish line comes into sight. I'd like to make 3 brief points that focus on promoting equity, both within priority phase 1 and beyond the consideration given to the priority group. And I'd like to note that these comments build on collaborations with a number of colleagues, but in particular the outstanding economists Haifun Semres, Grubenberg, and Parag Pasak. So the first point is that allocating vaccines to states according to population does not help reduce inequity, which I take to be a central goal of the framework. For example, in New Hampshire, a little over 1 in 10 people is among the most disadvantaged nationwide, but in New Mexico, more than 3 in 10 using the SVI standard that the committee also draws on. And there are similar variations in the populations of healthcare workers, of course. So if we send vaccines to states based on the population, disadvantaged groups in states with above average shares face more fierce rationing. But that's not fair. It would hence be helpful to use the ACIP standing to urge more fair allocation to jurisdictions that takes into consideration their shares of disadvantage. Second, and related, the committee can still recommend that jurisdictions set aside extra vaccine amounts for disadvantaged populations. The NASEM report, which sought to assist ACIP specifically with addressing equity, recommended setting aside a 10% reserve at the federal level. While there's much other similarity between NASEM's overall approach and ACIP, this proposal seems not to have carried over. This is regrettable, as we've shown in a study that a 10% federal reserve is the most beneficial for disadvantaged groups, including healthcare workers. But we've also shown that a 10% reserve at the state level can still meaningfully help disadvantaged populations. Pragmatically, and given where we are, it would hence be helpful if ACIP took up the NASEM's work and recommended that states and other jurisdictions strongly consider a 10% reserve based on SBI or related measure to further promote equitable allocation within each population group. In a separate study that we'll launch tonight, we compared all 64 jurisdictions' initial allocation plans and can report that the state of Tennessee already plans to do this, set aside a 10% reserve. So other jurisdictions can likely learn from this approach, as well as from 17 other states that plan to use the SBI to promote equity for worse-off populations in different ways. And lastly, technology can, of course, also enable equity. At an early meeting, ACIP suggested that the SVI could be integrated in the Tiberius software, and from the tenor of the discussion then, I assumed that this would be to enable jurisdiction planners using Tiberius to prioritize disadvantaged groups using SVI, but this seems unclear. Our analysis of the plans also show that 23 states currently plan on using Tiberius, including 15 that don't otherwise plan to use SVI for equity promoting purposes. So the index may do more work here, and it would be helpful to have clarity on this point. So in summary, aside from considering equity in the sequence of priority populations, ACIP can still promote equity further by recommending allocations to jurisdictions not by population, but by their share of disadvantage within healthcare workers or otherwise, recommending 10% reserves for disadvantaged communities at the state level, and building in SVI weights into Tiberius platforms as
Thank you for your comment. Time has expired. Thank you. Next speaker is Mr. Cubbins.
Yes, I am Kermit Kubitz. I was a polio pioneer in the 1954 vaccine trials, which ultimately reduced polio cases from 55,000 to 5,000 in the next 2 years. The recommended vaccine allocation priorities are well thought out based on goals of maximizing benefits, protecting public health and the healthcare system, and providing equity. You will vote on providing vaccination priority to healthcare workers in phase 1A. You may want to clarify that firefighters who act in many cases as healthcare workers and roll out to provide EMT services are included as healthcare workers for phase 1A purposes. My second recommendation, similar to the last speaker, is that geographic and state allocation of vaccines must recognize population densities and the availability of ultra-cold storage and allocate less stringently stored vaccines to state and rural areas within states without deep cold storage if two different kinds of vaccines are available. Third, follow-up of vaccines should include not just safety, but studies of effectiveness based on different populations and groups, potential flaws in logistical distribution and handling of vaccines, delays in dosing or other issues which can affect effectiveness. So there should be follow-up. Fourth, and I emphasize this, remember and plan to avoid laxity in non-pharmaceutical interventions such as masking and distancing by vaccinated persons interacting with unvaccinated populations. The vaccine may limit symptoms and illness, but may still allow infection and transmission. So you must have a plan to assure masking and distancing are still implemented until vaccines are widely available and used. And finally, as essential workers, I do recommend giving some priority to people who have participated in vaccine trials and received a placebo. Once an approved vaccine is available, those who received a placebo should get the vaccine even at the cost of less follow-up of a placebo group because they, the trial participants, are truly essential workers. And just to clarify on EUA fact sheets for everyone involved, it is my understanding that one thing about an EUA vaccine is that people do have the right to choose not to use a vaccine approved through EUA. That is, EUA vaccines are voluntary. Thank you.
Thank you for your comments. Next speaker is Dorrit Reese, please.
My name is Dorit Rice. I am a professor of law at the University of California, Hastings College of the Law, and a member of the Vaccine Working Group on Ethics and Policy. I have 4 points to make. ACIP plays a critical role making recommendations that the Public Health Department and healthcare provider recognize as authoritative and fact-based. ACIP recommendations are always critical, but even more so in a public health emergency, particularly the kind of fast-moving emergency we're in now. While the public may not be aware of all that ACIP does, the public benefits from the deliberations of this committee and relies on its expertise. It is critical that ACIP continue to play this critical role for COVID-19 vaccines. Second, in previous commenting sessions, members of Correction Officer Association asked you to consider including their members in the highest tier. I support the recommendation, and it's clearly too late for this part, but I want to reinforce the message that while level of outbreaks in jails and prisons were not as bad as in long-term care facilities, they were high. And in both cases, we have a captive population, and many in prisons and jails are at high risk. Correction officers are the bridge to the community and may bring in COVID-19, but they're not healthcare workers. They're not covered in the first tier, most of them. Maybe they should be, because prisoners are exposed to COVID-19 through no choice of them. Many are in prison for things that don't deserve COVID-19 as a penalty, and some are in jail innocent. Third, and this is a bit of a response to the previous comment, although the FDA and CDC had previously categorically stated that EUAs do not allow mandates, I think that's a misreading of the statutory language. The statutory language allows the Secretary discretion on whether mandates are allowed, and a categorical prohibition on mandates by private business may be vulnerable to legal challenges as a misuse of discretion. I think the advisory committees need to consider to what extent an EUA should allow mandates. And that's more to FDA than to you, but I want you to be aware of this. Finally, to echo comments I made in the past, I think ACIP should make public participation in its deliberations written only, at least for the near future. As you all know, all commenting before you have been used by anti-vaccine activists to create propaganda movies for their own community, under the heading of, these are our comments to CDC. Transparency is important. Participation is important. But contributing to anti-vaccine propaganda is not a legitimate role for ACIP. You are promoting transparency by having this public discussion, and you should keep doing that. You're providing an opportunity to public participation by having easily accessible written comments. You do not need to also provide a platform for making anti-vaccine videos. Thank you very much.
Thank you very much for your comments. Let me go back to Dr. Foreman and see if he is available. Stephanie, do you see him in the waiting room by chance?
No, Dr. Romero, I didn't hear back from him either. He must have not been able to wait.
Okay, thank you very much. So then this closes our public comment section. We thank all of the public speakers for taking the time to address us. I'm going to ask the voting members to please unmask themselves or open their videos as we move to the next stage.
And Dr. Romero, I just want to let the viewership know that the public docket, while it is open for acceptance of comments at this time, it will not be open for review by ACIP members or the public until tomorrow, but it will be open at the link tomorrow.
Thank you. Very good. Then, Dr. Dooling, can you put your slide up, please, with the motion in a second? All right.
Sorry, we have reworded in accordance with feedback received in the last round, and we're just going to put that reworded that just clarifies the intent.
Okay. I believe because there has been a change in the wording, we're going to need a motion and then a second once again.
Dr. Romero, because the wording is incredibly minor and just for clarification, there's no change in the intent of the recommendation. We can go with the original motion.
Very good. It's so deemed.
Next slide, please.
Dr. Dooley, would you please read it again to the committee for vote?
When a COVID-19 vaccine is authorized by FDA and recommended by ACIP, vaccination in the initial phase of the COVID-19 vaccination program, Phase 1A, should be offered to both healthcare personnel and residents of long-term care facilities.
Thank you. So, are there any other comments from the voting members? Okay, I see none. So I will call the roll and ask for a vote. I will then tally the votes and announce the results, and then we will open for comment. So as chair, I will vote last. Let me begin with Dr. Atmar. Dr. Atmar.
Atmar, yes.
Thank you. Dr. Alt.
Alt, yes.
Thank you. Dr. Bata.
Bata, yes.
Thank you. Dr. Bell.
Bell, yes.
Dr. Bernstein.
Bernstein, yes.
Dr. Fry.
Fry, yes.
Dr. Hunter.
Hunter, yes.
Dr. Lee.
Lee, yes.
Ms. McNally.
McNally, yes.
Dr. Paling.
Paling, yes.
Dr. Sanchez.
Sanchez, yes.
Dr. Szilagyi.
Szilagyi, yes.
Dr. Talbot.
Talbot, no.
Did I miss anybody in that roll call? Romero, yes. So my tally, which I will ask Dr. Cohn to confirm, is 13 in the affirmative and 1 no. Is that correct, Dr. Cohn?
Yes, Dr. Romero, that is correct.
Therefore, the motion passes, and the recommendation, interim recommendation, stands as: when a COVID-19 vaccine is authorized by FDA and recommended by ACIP, vaccination in the initial phase of the COVID-19 vaccination program, phase 1A, should be offered to both healthcare personnel and residents of long-term care facilities. So now I will ask for any of the voting members that wish to offer comment, and I will begin, if I may, as chair's prerogative. We have spent 8 months discussing and evaluating the data. I think that whatever we have asked for has been presented to us and has been clearly discussed both in the work group and in a public setting. Our discussions have been transparent and our motives have been clear. As is stated previously, we are using the principles of maximizing benefits and minimizing harms, promoting justice, mitigating health inequities. Those of us that are in the area of public health at this time see the growing number of cases that is coming before us. We see the growing number of healthcare providers that have become infected, and some of which unfortunately have passed away. We see that the individuals living in long-term congregate facilities, long-term care facilities, are at exceptional risk for mortality and morbidity due to this virus and disease. I believe that my vote reflects maximum benefit, minimum harm, promoting justice, and mitigating the health inequalities that exist with regard to distribution of this vaccine. It is because of that that I voted in favor of this motion. We'll take other comments if anyone wishes.
Dr. Romero,
Oh, go ahead, Veronica, please go.
on the policy question before us today, I voted yes after careful consideration of the science, the implementation considerations, and the ethical principles. It became clear to me that this should be the vaccine allocation priority for phase 1A. As a consumer representative of the ACIP, I place significant value on the routine safety surveillance systems
and new systems in place that the ACIP has asked the CDC to be sure to employ and to be sure to meticulously assess the data gathered. I want to note that I am also confident that the consent assent issue for long-term care facility residents required to receive the vaccine will be given the attention it deserves, as we heard today, in reassurance by Drs. Oliver and Messonnier. I would like to close my comment by thanking the COVID-19 team at the CDC for your incredible efforts thus far. We owe you a debt of gratitude that I don't think that we will ever be able to adequately convey, and we look forward to continuing to work with you during this challenging time. Thank you.
Thank you very much. Dr. Paling, I see your hand is up.
Yes, thank you. I wanted to, I voted yes, and I also was focused on maximizing benefits, minimizing harm, promoting justice, and mitigating inequities. Healthcare personnel have high exposure to COVID-19 and need to be available to meet the increasing health needs of all Americans. It's important to emphasize and include the full diversity encompassed within healthcare professionals, as well as the opportunity to mitigate inequities. I encourage all who will receive COVID-19 vaccines to volunteer to participate in the VSafe established to efficiently monitor safety of all COVID-19 vaccines. Post-approval monitoring of vaccine is standard for many decades, and individuals and providers have the availability to report and are strongly encouraged to report to VAERS. VAERS is co-managed by the CDC and FDA for all vaccines. As to the long-term care facility residents, they have high risk, as is demonstrated by the fact that less than 1% of the population, they represent less than 1% of the U.S. population, yet they represent a disproportionate rate of disease and death. 6% of all COVID cases and 40% of deaths. The efficiencies gained by administering vaccine to residents and staff with pharmacy partners really is important to acknowledge. The consent and assent process for the long-term care facility is appropriate and needed and nicely complements the enhanced safety surveillance systems established. While it would be nice to have additional data on this population, that is not feasible during this pandemic, and with the disproportionate share of deaths belonging to persons who live in long-term care facilities, I believe it's important that they be included as well. Thank you.
Thank you for your comments, Dr. Paling. Dr. Szilagyi?
Yes, thank you. First, I wanted to really thank the COVID-19 work group and the enormous CDC team and liaisons for the incredibly careful, thoughtful, collaborative work. This has been just an amazing experience, and I'm honored to be participating in this process. To me, this has been a Solomon's choice, since we all feel that all U.S. residents should eventually have access to safe and effective vaccines, but we will all have access very soon. I strongly agree with the recommendation to allocate both healthcare providers and residents of long-term care facilities to phase 1A, with the assumption that FDA and ACIP would only recommend a vaccine if the best available evidence shows it's effective and safe. I do feel this prioritization represents strong consideration of the frameworks of science, implementation, and ethics, and helps to maintain our healthcare system and protect a very fragile population. And finally, I want to emphasize that post-recommendation guidance and support for implementation and safety monitoring is critical, and as we heard today, it's being planned extremely well by CDC. So I just want to end by something that I sometimes talk about in talks. One of my favorite people, Mahatma Gandhi, said, "A nation's greatness is measured by how it treats its weakest members." And I feel prioritizing healthcare providers and prioritizing residents of long-term care facilities represents the right decision at this time. Thank you.
Thank you, Dr. Szilagyi. Dr. Bell.
Thank you. I wanted to simply reflect on
the weight of the decision that we are making today and the process that we are embarking on, and to say that, we all would like to know more, but there comes a time when we go through a process, we evaluate carefully every bit of information that we have access to, and then we need to act. And I find that the consistency with which all of my colleagues on the ACIP are essentially coming up with the same way of looking at the evidence that's available to us and coming up with the same conclusion of the conclusion for this moment. And I think that is an important part of all of this, that we are acting now in the way that maximizes benefits and minimizes harms at this moment, and we will continue to go forward as we're able. So I in addition to thanking all of the CDC people and the work group, I also just wanted to reflect on and thank my colleagues on the ACIP for continuing to work through all of this with all of us and, come up with a very similar assessment of what is the best choice to make at this time to save the most lives and prevent as much disease as possible.
Thank you, Dr. Bell. Dr. Lee.
Thanks very much. I just wanted to make a couple of brief statements. So, I really see our job at ACIP is to take care of the public at a population level, and then our job as healthcare providers is to take care of individuals of the public at the individual level. And phase 1A, I think, enables us to hopefully preserve that healthcare capacity before it's too late. And I really wanted to thank all of our frontline workers for all of their service to date. It's been an exhausting 9 months, and all of us are in this together, but really appreciate how much our healthcare delivery systems and our public health colleagues have done. For the residents of the long-term care facilities, I just want to recognize and really appreciate my colleagues' comments about continued vigilance around safety surveillance for all populations, but in particular this population. I do want to recognize that this medically fragile population has a high risk of mortality without COVID. I hope that this creates an opportunity for us to prevent mortality in this population that's attributable to COVID. So hopefully this will have substantial health impact on that high-risk population. Finally, I just wanted to make a statement that we must address health equity as a core component at every stage of allocation. And, our job is clearly not done. We are just at the beginning part of this. So I wanted to take a moment to thank our colleagues at CDC, at all the states and jurisdictions for their leadership during this critical time. It's been really challenging, and I have really appreciated how so many people have stepped up, given all the challenges. And the implementation of this will belong to all of us, and we'll continue to need to work together in order to get through this pandemic. Thank you.
Thank you, Dr. Lee. Dr. Alt.
My comments were going to be very similar to everyone else's comments, so I don't want to duplicate too much. However, I have been participating in ACIP meetings for the last 15 years in various capacities, and I thought the discussion over these last few meetings has been excellent, along with the presentation, and certainly transparent and very well done for everybody that was involved.
Thank you, Dr. Alt. Dr. Talbot.
Odd woman out, I guess. I wanted to say a lot of things. One is I still struggle with this. This was not an easy vote. Two, I really hope this highlights that our skilled nursing facilities are a population that needs lots of vaccines, not just COVID. And we really need to start finding ways of developing and testing these vaccines to prolong quality of life for our long-term care facility residents. I think that's key. I also want to say out loud that I have no reservations for healthcare workers taking this vaccine. We are going to see some amazing data about a respiratory vaccine like we've never seen before, and it's incredibly exciting. And I want the healthcare workers out there to know that I have no reservations about that whatsoever. So thank you for letting me serve, and I'm very glad it's a village and not one person.
Thank you, Dr. Talbot. Dr. Sanchez.
Okay, sorry. Sanchez, I really want to just take the opportunity to echo the previous comments and applaud the CDC COVID-19 team for their wonderful and astute guidance. I feel very strongly that we must vaccinate our healthcare workers so that they can remain healthy and uninfected, so that they can provide care for the entire population. To me, that's completely clear. And I also feel very strongly that we need to protect the highly vulnerable elderly population and others who provide their care in long-term facilities. In many ways, I really feel that those are the ones who should come first, because they've given so much already to society. I recognize the continued need for optimal safety monitoring, but I really am convinced that this will be the case as we see this pandemic continue and cause significant harm to our society and to people. Thank you.
Thank you, Dr. Sanchez. Dr. Atmar.
Thank you, Dr. Romero. I want to add my thanks to the COVID-19 work group and the workers at the CDC for putting the data together over the last many months that we've had to consider leading up to this initial interim recommendation. I'd like to also remind everyone that this recommendation is only for vaccines that end up being recommended by the ACIP. So as individual vaccines receive emergency use authorization, we will have more data to consider, and that could lead to revision of our prioritization based on the content of the EUA and the data that support it. And while I shared many of the concerns that led Dr. Talbot to her vote about residents of long-term care facilities, ultimately I was persuaded by the tremendous burden in terms of mortality and hospitalization that the residents of these facilities bear, the remarkable efficacy that has initially been reported that ultimately we'll have a chance to review, being much greater than what we've seen with influenza vaccines. And so there is at least some hope that it will have some level of efficacy in this population. And the plans for monitoring of safety in this population and the extra mile that will be pursued to make sure that both the residents and their families are fully informed about the amount of evidence that's available before the residents receive the vaccine. That concludes my remarks.
Dr. Romero, do you want me to go to the next person?
I'm sorry, I was muted. I called Dr. Fry's name. Forgive me. Dr. Fry, please. And forgive my oversight.
Thank you. I also would like to thank the COVID working group and all the CDC members who have participated heavily in this process, as well as their consultants, and also the the representatives of the professional organizations who also are able to interact with us at these meetings for all the outstanding work that they have done. Actually, Dr. Atmar said what I was going to say, is that what we are looking at here today is allocation of vaccine and not voting on any particular vaccine. and that we are trying to figure out the best way, and this is not an easy process, but to figure out the best way to allocate vaccine when it is available. There will be other votes for for recommendations for use of vaccines when the time is proper. So this is really just an allocation exercise. And so even that in and of itself has been extremely, I think, angst-provoking for many people. But I strongly agree that we are headed in the right direction here. Thank you so much.
Thank you very much for those comments. Ms. Bata.
Thank you, Dr. Romero. As we have been deliberating over this very first group of people who will get some limited doses of vaccine, I've received many pleas from many people all over our jurisdiction to consider them as a priority, and I'm encouraged by the fact that we have some vaccine products that are on the verge of becoming available. I appreciate the desire that so many people have to get protected, to move us beyond the terrible disease that we're seeing, and to encourage them that even though they may not get these first doses, it is important to protect them too. And I look forward, as others have mentioned, to moving into the approval process of the vaccine products that will become available once we've reviewed the data and acknowledge that this is an allocation recommendation and not a vaccine recommendation specifically. Thank you.
Thank you very much. Is there anyone else who wishes to make a comment from the voting members? Dr. Cohen, Dr. Massonier, do you wish to make a comment?
This is Dr. Cohen. I would just like to thank the ACIP committee, liaisons, ex officios, the ACIP COVID-19's work group and the safety subgroup, as well as our fearless CDC leads for those work groups and team for all of the work that went into this over really since March or April. I also want to let everybody know that we anticipate that the next ACIP meeting will occur sometime after the VRPAC meeting, and ACIP will be voting to recommend products after ACIP has reviewed the data from the phase 3 clinical trial, and after FDA has authorized, has issued an emergency use authorization for a product. So we will not be having a meeting in the interim, but we do anticipate having a meeting shortly after the December 10th VRPAC meeting, and more details will be made available soon. Thank you.
Thank you. Anybody else? Dr. Massonier, I don't know if she's still here.
No, I'm still here. I will just add thank you to the public. And to Dr. Romero. Thank you to the public and for all the folks that are out there listening to what we consider really an incredibly important meeting, and to all the people out there that are anxiously waiting for this vaccine. We hope that this vote gets us all one step closer to the day when we can all feel safe again and when this pandemic is over. Finally, I'd like to thank you, Dr. Romero, for presiding over this meeting so well, and frankly, for all the work over the past year that you've given to the ACIP. We really do appreciate you. Thank you.
Thank you. So anyone else, last chance? All right, then I'll take Chair's prerogative to make this very short. Again, I think everybody has mentioned their thanks to our work group leads. I want to give my thanks in particular to Dr. Bell, our work group chair, all the members of the ACIP, all the support members of the CDC that have supported us throughout these months. It is an incredible honor, and I'm humbled to lead you all. So thank you all very much. we will see each other, I think, in a few days on video again. Be safe. And with that, if I had my gavel, I would gavel us out. But imagine the sound of a gavel. We are over for the day. Thank you very much. Meeting ended.